everybody. Can y'all hear me?
I can hear you.
Great. Is that Kirsten? Kirsten? I've got one. All right. Most of y'all are muted. I'm going to unmute y'all for a second. We're trying to get this new technology down. So hang on one second. I'm familiar with Zoom, but seeing how I'm with Alliant once a year, I'm going to practice just a little bit with y'all so we can get all the information together. So let me see something. Mute, play, rename. No. All right. All right, we're recording. I'm going to unmute you for a second, so y'all just tell me if you can hear me. If you cannot hear me, let me know who you are, okay?
At the moment I was able to let go.
We can hear you.
Hello.
What I thought it was.
Hello.
Hello, I can hear you.
Hello?
Yeah.
Hello, sounds like you got a lot of background noise.
Oh, it needs to be in there.
All right.
Oh, and I need to be
Yeah.
once I let go of the concept and construct.
It might be better for each of us to mute ourselves and at a time. You can call our name.
So I invite you to sit with
Okay.
that.
Maybe we should
All
mute.
right. I can hear you. I can hear you.
Doctor,
Heather.
Doctor, if I may
makes a lot of
interrupt the
sense.
class.
I mean, I actually came from the exact opposite.
All right. So
My parents were from different.
Heather, can you hear me?
And so they just didn't do anything with us.
I've
which
got
left
someone
me very
talking,
open
so
in a good way.
hold on. I'll do it another way.
I understand what you're saying, and I want what you're describing, which is that
Evidently somebody's working, so let me unmute y'all.
prayer, that practice.
I can get back. All right.
Sorry, Doctor, I had to mute all. On the Zoom, everyone, unlike the Collaborate, people here can unmute themselves.
Okay. All right.
I can see your PowerPoint is showing. Just show Dr. Meryl Norton and your email address and your phone number.
Yeah. Yeah, I want everybody to know that's my contact information. So if something comes up during the next 2 days, you can email me or text me.
Michelle Cochran, the education
so that I will know.
and Todd Hutton, they both came out and said that they can't hand these out.
Okay.
This is promotion, and this is an educational course, and if
Okay. Are we ready to go? I've got 24 participants in the house. Okay, very good. Well, good morning, everybody. My name is Meryl Norton, and I am going to be your instructor for the next 2 days, specifically dealing with substance use disorders. I have done this particular course several years for Alliant. It's very intense from the standpoint of a lot of information over a very short period of time. There will be some questions that we will go through as I go through the PowerPoints. Today, we're going to cover this morning, we're going to cover the basics of the psychopharm of substance use disorders. If I can get through all of that before we get to our lunch break this afternoon, we will cover specific classifications. I'm going to cover probably the 5 most important classifications for sake of information, as well as for the information that needs to be, I think, applicable to what y'all are going to do in practice. There may be other questions, but there are some classifications that we will not cover because we simply do not have time. Tomorrow, I will go over in the morning, go over treatment aspects. And then tomorrow afternoon, we will work on case studies. There are 10 case studies that have been placed on Moodle. It will be informational. So what I will want you to do, and I'll go over the instructions of that later this afternoon in case some of you are wanting to get into those. Basically, these are cases that you will review, give me some diagnostic code criterias have to do with DSM-5. I have produced a very short and a sheet on the DSM-5, so you don't have to pull out your DSM-5 and dig through all of that simply for time's sake. But anyway, we'll get some ideas of the different disorders as well as the criteria and other issues that you may run into as a part of the course. So I hope this will be helpful. I hope it will be something that will be somewhat enjoyable, even though I do not look forward to spending 6 hours talking to a computer. I much rather have a live classroom, but I've done this before, so we will see what we can get done. If there are questions, and again, because of the type of screen that I have, and I'll go to a full screen, I will see if you can text me questions as we go through it. I will check those because I will be taking a short break on the top of each hour, about 5 minutes. So when we get to 1 o'clock, I will stop and take a 5-minute break. When we get to 2 o'clock, stop and take a 5-minute break. And hopefully if you need some water, whatever you need to do, you can do that. At 3 o'clock, we will take our lunch break. We will come back at 4 and continue again hourly. We'll take the breaks until we end the course. I'm in the Eastern time zone, so that's why I'm looking at, I know most of you may be in the Western or maybe in other time zones, but I'm in the Eastern time zone. So I'm starting at 12 noon and my time will be ending at 7 p.m. Eastern, whereas some of you will be ending at 4 o'clock Pacific. So if there are any questions, please let me know as we go through this. As I try to spend some getting somewhat familiar with the Zoom process, whereas I'm used to Collaborate, whereas when we have the PowerPoints on, I can actually see questions as they come up, and hopefully we'll be able to do that. So with that, we're going to begin. I know that y'all have been doing this for some time, so we're going to get the first set of slides, which all the slides that you have that are on Moodle, the PowerPoints, I have not changed those as far as I'm aware. Tried to put all updated everything, so we should be able to follow those and do that in the appropriate way. So let me get ready to share this with you. Okay. And now here we go. All right, here we are. All right, I'm reading your chats and I got that. All right, please let no one know that we are mostly use the chat feature that people have responding to him. All right, I'm reading that. I got that. Okay. All right. Very good. Thank you. Thank you. Thank you for chat. All right. Let us go and see if we can get this done. All right. Here we are. I have a beautiful picture of from the University of Utah. I teach out there at a summer school. Been doing that for a number of years. My background, by the way, for you that don't know, is that I'm a doctor of pharmacy, specializing for psychopharmacology specific to mental health and substance use disorders. My training and background is multifaceted, probably more from the interest of treatment. Work with a guy named Doug Talbot. Dr. Talbot was the father of addiction medicine. I watched him evolve that specialty into medicine in the mid 80s, late 80s. He trained me to teach primarily physicians and other healthcare practitioners to specifics of medication that will be used in the treatment of mental disorders in conjunction with substance use disorders. And as evolutionary would have it, the process, I evolved with specialty in pain management. So for the last 20 plus years, I've been addressing chronic pain issues in those individuals who also are diagnosed with substance use disorders. So, well, I'm glad. Yeah, I love the University of Utah. It's a great place. Wonderful, wonderful place to go and train and teach. But anyway, so that is a beautiful sunset as we look at it. So we will move from there. But anyway, I wanted you to start with some kind of relaxing scene before we get into all of this. So, and that is the issue. All right, so my title to this is The Introduction of Substance Use Disorders, Implication for Clinical Psychologists, and I'm trying to gear it to what your practice. I train also for Fairleigh Dickinson University. I do, in that curriculum, I deal specifically with the pharmacology. And so we're going to, I really get excited about training you specific to substance use disorders, because I know a lot of you have different backgrounds and probably have a lot of experience with substance use disorders. My experience with these particular groups of psychologists, some don't. And so my goal is to try to bring the person who probably has the least experience and information back to understanding what we know about substance use disorders as it applies to 2020, and how it will be applicable in your prescribing practices as we move forward. I will talk about medications. In the role that I am a clinical professor, so I am in the clinic 3 days a week as a role, as usual, and my specific is not only dealing with the pain issue and monitoring with the treatment team, but also ambulatory detox. I am probably a specialist in that area, dealing with alcohol, opiates, and benzodiazepines. And we, of course, now that we have a high dose cannabis, we're dealing with some other issues. So we'll talk about that some when I get to that issue having to do with it next in the morning. So we'll see what. So our learning objectives are there. I will not regurgitate these because of time. You will see that we will talk about the definition of a substance use disorder according to the DSM-5. I'm also going to spend some time talking about the pathophysiology of the substance use disorders, and also look at symptoms of poor impulse control, compulsiveness, and other, and explain that probably from a biological standpoint as far as what we know, in order to help people become teachers of individuals coming in. I think one of the greatest things that we can do is not only help intervene on people, but also train them and teach them about their disease. And the more we know about their disease, the more people appreciate and actually understand what they need to do to comply. And so it's one of those things. So the thing about it is, we also look at the misconceptions of substance use disorder and stigma. As y'all probably are better aware, and any other group that I have to deal with are aware of the overwhelming stigma of mental health disorders, and especially substance use disorders, that prevents people from really seeking treatment, and families from seeking treatment because of the shame and a stigma attached to that. We'll also talk about how it impacts families somewhat. I won't spend a lot of time with that. We'll talk about it. Also look at the evidence-based treatments that are currently available. List associated approaches, different types. We will talk about the American Society Addiction Medicine patient placement criteria 2. That will be some of what you will be involved with your cases, because when you look at your cases, and there are 10 of them, and you will post these back to me once you finish answering these, and send them back, and I'll give you a grade. And what that grade is for is extra points when it comes to looking at your final exam. But the thing about it is, I want us to walk through these, and there are several different ones. But we will look at also where you would place these particular patients based on this particular criteria. We look at the strategies of common emotional reactions, reacting addictive behavior. So how do we help people who are maybe being under a lot of stress as a result of family dynamics, legal dynamics, and others, and how we can help them move through that. We'll also look at recommendations and how we can also help people understand not only the individuals, but also our peers. I'm in pharmacy, and believe it or not, pharmacy is probably the most resistant and have been the slowest to train in the groups having to do with substance use disorders. I came to the University of Georgia out of an international consulting career, specifically to build curriculum in the graduate school level. So what I do is I teach MDs, PhDs and PharmDs to understand it. Part of that training is what you're going to get over the next 2 days. So one of the things that we will do, and that's what this is about. Now, when I use the terms addiction and substance use disorder, again, substance use disorder was introduced in 2013 as the appropriate term to use with people who have an addiction. The reason for that is to eliminate the stigma or the loaded terminology of addiction. But in this discussion, because I've had 30 years of specifically talking about addiction and probably less than 5 to 6 years talking about substance use disorders, in my discussion, it will be interchangeable. So I'll try to use substance use disorder, but it will be interchangeable as we go through this, okay? So here's your self-assessment questions. ASAM definition of addiction states that addiction is a disease that includes all of the following criteria except the disease is primary, the disease is chronic, the disease is curable, the disease is relapsing. So you can answer that and we'll talk about these. CC, I see, C, very, very good. I try to give y'all an easy one to start with. But also I want you to understand the explanation of what it's about. That's right. That's right. I got it. Very good. Very good. The second self-assessment question is all drugs of abuse and many behaviors have the following in common. A, they're illegal. B, they eventually produce addiction in people who abuse them. C, they release dopamine in the nucleus accumbens and the ventral tegmentum. And D, the release of serotonin in the midbrain. So, question 2. Let's see what y'all have. Yeah, okay, all right, very good, very good, very good. And I know some of you perfectionists are waiting to see what I say. All right, very good, very good. C, 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 C. Well, the answer is C, and we will explain that to more definitive situation. Now, self-assessment 3, psychoactive drugs create a blank for a drug, which causes a release of dopamine and may have consequences. Psychoactive drug use creates a blank for the drug, which causes a release of dopamine, which may have consequences. A wanting, B, a craving, C, a liking, D, a loving. B, B, B. Now look at your terms, y'all, very carefully now. That's what we're going to talk about. Psychoactive drug use creates a blank for a drug which causes a release of dopamine and may have consequences. Okay? Everybody answered? The answer is C. The evolution component of drug use is the first stage that may lead to a substance use disorder. So one of the things that we will see, and we will talk about this a lot in this discussion, is the first thing that our brain does is when it releases dopamine, dopamine creates a liking. It creates a triggering mechanism that I particularly like this because it creates a release of pleasure or relief of stress or those types of things. But the first thing that happens is liking. So it's a good question because most people, it's not a craving. Well, to explain craving, craving is important. And the loving component of it is important and the wanting is all tied to this, but there's kind of a sequence that we'll go through. Okay. Now, this is probably more academic. In the theories of stress and addiction, Kuban and Lamotte proposed that when the brain's hedonic system is unable to maintain homeostasis in the face of escalating drug use, it resorts to A, frontal hypofunctionality, which is a failure of the top-down control of the prefrontal cortex over the midbrain. B, anhedonia, which is the inability to derive normal pleasure from normally pleasurable activities. Or C, allostasis, which is an attempt to reestablish comfortability through change. C, 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 C. Maybe y'all look to the answers at the end of the end. C is the answer, allostasis. And it's a huge issue, y'all. This is the chronicity of a substance use disorder. Homeostasis is complete balance of the central nervous system and trying to make it okay. I mean, you get, you know, as I will talk to you about it from a psychopharm standpoint, for every second of stimulation in the brain, which is a release of norepinephrine, epinephrine, and dopamine, they are 3 seconds of depression, which means there's a release of serotonin, GABA, glutamate. So if you overstimulate the brain as a result of activating the reward brain, the reward centers, for a prolonged period of time, what happens is you create an imbalance. And that's what this allostasis and what Koob and them talk about in the inability of this brain to reestablish homeostasis as it relates to normal pleasures. And so we'll talk about that to a good bit of our time. And so we will see what we can do. Glutamate is one of the many neurotransmitters affected by the disease of substance use disorders. Which of the following statements are false about glutamate and its role in the addictive process? A, it's the most abundant neurotransmitter in the brain. B, it's critical in memory formation and consolidation. C, drugs of abuse and other addicting behaviors affect glutamate by blocking drug cues. And D, glutamate initiates drug seeking. So I have D, I have C, I have D, I have D, I have D. I have D. Which one is false? It's C. And we'll talk about the new research we've discovered about glutamate and the issue of how it affects, it stimulates and activates drug cues. It also, and that's what creates D, it initiates drug seeking. And we'll talk a lot about this in understanding kind of the behavior associated with substance use disorders and why people have that particular issue and also why they're so negative, why they come in and they're very resistant to treatment. So hopefully it will be something that we'll be able to do. And so how many of you know someone who has a substance use disorder? How many of y'all know somebody? Yeah. Probably in the backgrounds of most of you, if it's not in your own family system, it may be a friend or some of you, Joy said she works in addiction. Many of us in the mental health field, seeing how 35 to 45% of the patients we may see may be experiencing or have experienced a substance use disorder, know that. So we need to be familiar with this. And that's what I have spent most of my career educating people, even though I have other areas of expertise. I'm trained in oncology. I'm trained in anticoagulant therapies. I'm trained in emergency medicine. I have many other types of credentials, but I stayed with substance use disorder because I find that the educational component as a rule is far from the same as with other mental disorders or with other physical disorders. And so we have that. So do you know what happened to cause substance use disorder? And if you do you have a way to explain it to your particular patients in a way that they can understand? So do you know what happened? Do you know the sequence? So, and I'm sure a lot of you do. But the thing about it is what I am trying to get to is what is a substance use disorder. You know, Rebecca says, right, everyone is different. And that is true. Not all substance use disorders are individualized. They're all very different. and trauma, genetics, overprescribing, lots of different environmental issues. So let's see what we talk about. So we're going to talk about the substance, neuroscience, and psycho. Now, what I want you to remember, and I said this in 2003 at a major conference. I think I was in Colorado Springs at somewhere, and it came about as some of the research. Addicts are addicted to pain, not pleasure. It is pain that is predominant in their brain. It is an issue that seems to be a constant, something that has to be looked at from the standpoint of relapse prevention. If you're going to get someone into a sober state, they're going to have to understand the triggering mechanisms. And that's kind of what this whole process is going to be about for us this morning, is for me to try to consolidate a semester of work within a 3-hour period. But it is something that has to do. And yes, Carmen, it has to do, there's a negative reinforcer, and there's a part of that. So self-assessment, question 6. According to the American Society, definition of addiction includes that addiction is a progressive incurable disease process that results in premature death without treatment. Is that true or false? A or B? Yeah. It's true. If you look at it, it's progressive, it's incurable, and if it's not treated, the average age of life lost in a alcoholic, and this used to be significant, and it still is about 21 years. The average age in a person who dies from opioid use disorder, they've estimated recently, is almost 40 years. The average age of death that has occurred in the United States because of opioid use disorders and the epidemic that is currently underway is around the age of 27. So much so that the average long-term age for individuals in the United States has decreased by almost a year and a half as a result of that. Yes, that means that they will die early. They die prematurely. If we estimate women 77, men at 72, some countries have 80, some men, it's just one of these things. But we do know that without treatment, they die prematurely. Now, the definition, and this is kind of where we're going to start, it's a primary disease, which means what? What does it mean that it's a primary disease? What does that mean? That's a question. Not secondary to something else, Jar. That's right. First disease of many. That's right, Rebecca. It means it has to be addressed first. We have dual diagnosis, the old term of co-occurring disorders, where we have individuals who suffer from schizophrenia, they suffer from bipolar disorder, they suffer from OCD, all these others, but also may have a substance use disorder. We have to address the substance use, and then we try to address both of those concurrently, even though there's, depending on resources, it has to be looked at first. So it is a primary disease. It is chronic. It is a chronic disease of brain reward, motivation, memory, and related circuitry. That means it's not acute. It means it has no cure. It means it has to have constant supervision in the treatment modality. So we have chronicity as it relates. Most people think they just quit, and they do, but the problem is they start back because they think it's just quitting is the answer. And unfortunately, that is not the case with those individuals suffering from substance use disorder. Dysfunction in the circuits leads to characteristic biological, psychological, social, and spiritual manifestations. Joyce says, I work with eating disorder and substance use. It's often the case, what will kill you first, and that is what we focus on, often shifts fat. That's correct, Joy. It is what's going to lead. So if you've got someone, that's a great point. If you have someone coming in that has a bipolar disorder and also an opioid use disorder, what are you most likely going to address? Because we know that bipolar has a high suicide rate, opioid use disorder has a high overdose rate. So what do you address first? And that's why that's the complication. And that's why a lot of practitioners don't understand it takes more than one to treat most individual who suffers from a substance use disorder. And that's, y'all know this better than any group that I train. But most physicians I've run into, even the younger ones, and I'm in a med school here at UGA, and it's hard for them to understand that they can't treat them by themselves. They're getting to that point, but it's also reflected pathological rewarding and also relief by the substance use and the behavior. So that is reflected by the dysfunction. Addiction is characterized by the inability to consistently abstain. It also has an impairment in control, behavioral control. Craving, which we will talk about extensively, is a component of the definition now of the DSM-5. They've just added that as of 2013, but they've also placed it in the ASAM definition in 2011 because there's a craving, and we'll talk about that. Diminished recognition of significant problems with one's behavior and interpersonal relationships. And I guess the underlying, and that's why y'all are so important collectively as you address this, a dysfunctional emotional response from the individual as it relates to what their environment really is about, the reality of their world. And so ASAM has included that into this definition. Addiction, like other chronic diseases, involves cycles of relapse and remission. Without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death, as we've mentioned. So the bottom line of what ASAM talks about is addiction or substance use disorder is a progressive incurable disease process that results in premature death without treatment. Now, if you want the short version of what you need to tell people when they come to see you and you're done your assessment and you're going to give them the news that they have a substance use disorder, that is the sentence that needs to be included in your recommendation and in your report. It's a progressive incurable disease that results in premature death without treatment. And so one of the things I tell people is it covers the basis so people understand what they need to do. And that hopefully will be of help to them. Now, what I'm going to try to do today, sorry, let me back up. I jumped too quick. I'm trying to do all this so y'all can see this. For me to cover what we're going to cover in the Brain's Addiction Network is we're going to talk about addiction process. We're going to talk about the anti-reward brain system. We're going to talk about the BDNF system, the brain-derived neurotrophic factor system, which hopefully I know some of you or most of you are familiar with by now. We're going to talk about the brain stress system. We're going to discuss cravings. We'll talk about, and more specifically this afternoon, and that may overrun into some in the morning, the psychoactive substances on the market, in the marketplace today, genetics, the mental component, neurotransmitters, receptors, the relapse process, and also we're going to talk about the reward system as it relates to substance use disorder. So we're going to do that. And so as we do that, we do move forward. Now, as I talk about it and I throw these things out again, is trying to be a teacher for people who may have dysfunctional brains or can have limited learning capabilities early on. I try to make it kind of, brain system them up. We're going to talk about the pain brain. For the anti-reward system, it's the largest system inside of the brain. It regulates all types of pain. I noticed that National Geographic had a great article and a great series on the pain receptors, I think last month or so. Interesting reading anyway about how the brain responds and the neuromodulation of that. The BDNF system is what we have now come to believe is the mood brain. It's the regulatory component. You will see with your newer psychotropic medications in the very near future, you're going to have BDNF agonists. You're going to have BDNF antagonists. That will be your new generation of antidepressants, some antipsychotic capabilities, anti-anxiety medication, and those types of things as a result of the BDNF system. We'll talk about the stress system, which is actually the functionality system of the brain. It creates you from being overstressed or too anxious and too compulsive, or under stress, or creates depression and those types of things. It's a regulatory component. If you have either one of those curves, too much or too little, it creates usually dysfunction inside of a person's life. And again, that's what the DSM-5 has lots of diagnostic criteria about, but it relates from a neuroscience standpoint of this overwhelming system. Cravings is simply put is the brain's desire to seek balance or homeostasis. We'll talk about the drugs, which are the external molecules that simply change homeostasis. They're uppers, downers, and all arounders. And it's one of those things. Yes, it is very good, and it is also online. Thank you. And the genetics, the risk factors that change homeostasis. We'll talk a little bit about that, and also how that changes. We'll talk about the obsession. What brings about the obsession? Why does this brain becomes so obsessed with this particular set of chemicals or drugs? We'll talk about the essential 11, which are what our 11 families that are probably involved. There are many more, but these, generically speaking, are the ones that we have identified over the years that are involved as a result of substance use disorders. The receptors, the mu, the delta, the kappa, the glutamate, and GABA, all primary. Talk about the new thinking about mu, delta, and kappa, which are the opioid receptors, and how they are relatable to not just opioids, but to most all the other psychoactive substances. We are now looking at them as euphoria receptors generically, not just opioid receptors. The relapse process indicates, and really is not understood fully, about the chronicity of the disease. What happens? We think it has to do with the stress management of the biological component of the brain, and when it really is able to be taken care of. And of course, the reward system is the natural brain. It's talking about what brings us pleasure. And we'll all be pleased when this is over tomorrow afternoon. And we'll be able to go on with our lives and do some other things. But meanwhile, we may be in more pain than I would really want to admit. So anyway, we will see what we can do. So let's talk about the addiction process. This comes out of an old theory. It comes out of, actually, a lot of you probably are very familiar with this. L.J. Hatterer, the addiction process in 1982, has to do with this particular individual studying the individual process. And he said many things about this particular study, but he said no single addictive personality addiction process, I have an addicted personality. That was a great theory up until he began to talk about this. There is no single addictive personality that exists. In other words, regardless of the personality type and the personality profile, most any of those personality types can become addicted, is what he says. He also says they become addicted because of specific reasons. He said it can be defined, and it definitely can be diagnosed, as we now have a very clear but very confusing DSM-5 diagnosis. And we'll talk a little more about that tomorrow. But it's also, we got to look at the addicting component and trigger mechanisms that can initiate and perpetrate the process and potentiate the process. The thing is, we don't understand why some people can stay sober. They go to treatment one time and they stay sober a lifetime. And then we have some people go to treatment 10 times and they can't stay sober 3 days. It's a really interesting what happens and what is the reason behind that. But he said it has to do with the addictability of the brain and the risk factors there, and also what may trigger the brain. Our biggest concern from a pharmaceutical standpoint is how do we manage cravings, or what he calls trigger mechanisms. Cravings are set up due to stress. They're set up due to cues. And so how do we manage that? And so we're doing it. He also said that the process has a life history. In other words, it has many stages. It can be cyclic, where they'll go out and drink every 6 weeks, every 3 months. It can be periodic, where people will take long periods of abstinence. Some I've seen up to 3 years. It can be sporadic. It's not that everybody starts off at the same place. He also says the individual can shift from one drug of choice to another drug of choice, or can get into other behavioral processes, even though back then there was very little understanding of that. But he is the one who started the initiation to begin to look at that. And understanding the above factors is essential in making accurate diagnosis to treatment. And that's one of the evolutionary processes of what I do in my assessment. And I have all types of counseling and addiction credentials on top of my pharmacy stuff. But the thing about it is, I try to draw them a picture. I try to start with age of first use and begin to look at the process and as it begins, like I do with most other diseases. Being an ambulatory care pharmacist, diabetes being an extremely important component of that, trying to tell people about type 1, which starts, as child or an adolescent, and type 2 is adult onset. To explain that very similar, and that's what I do with this process here. And that's why I think this is extremely important to understand. They're very complex, probably more complex than most people will understand it to be. And so they're biological. So we'll talk about the changes in the brain. They're sociological, which has to do with how does the particular culture respond to an individual who has a substance use disorder. In our culture, it is very negative. And the psychological components, which are as a part of your world, is what makes that person continue to use in spite of adverse consequences. And why don't they stop because of their children, or because of their career, or because of whatever. Also, we have to look at the other issues that may contribute to the issue of a substance use disorder. Now, it has to do with biological deficiencies in the brain. And one of the huge components of that is trauma. Now, I will not really get into this in this discussion, but I have put together and are training on numbers of psychologists, psychiatrists, social workers, others, to the neurobiological components of trauma and the overwhelming changes in the brain that occur. And a part of this creates deficiencies depending on the age and the extent of when that trauma occurred. And some of you, I'm sure, are trauma experts, and so could probably educate me more about that. But this has to do with the psychological components of this disease. And so now, the good news is it's treatable. It is good. Yes. Rebecca, if you will send me, I don't know if you're Rebecca or Becky or Beck or whatever, but Rebecca, if you will send me an email to mernort@gmail.com, I'm more than happy to send you my book list. Thanks, Rebecca. And if you'll do that, I'll send you what I have. Yeah, there's some good information, new information about that. But when we look at substance use disorder, it does recover. As you will see here, the brain can recover. We have a normal brain, which has a red area, and that has to do with carbohydrate synthesis, metabolism, and other things, we believe. If I can keep it from going away. Let me back it up. There we go. And so when you see that, and what we believe happens is there's a depletion that occurs. As a result of that depletion, it has that brain that's in the middle, and that's a 30-day abstinence brain. And you see the red area, most of it is missing. But then after 14 months of abstinence, then the brain has begun to regenerate. And so what happens is the brain starts to heal. Does it heal at the same level? Does it return back to normal? That is a question we're still trying to determine, but most scientists said no, depending on age. Now, if you've got a 14-year-old brain that ends up very similar to what this brain may be, and you intervene on them 18 years old and it's not fully matured to 24, there's a probable good chance that brain could rehab itself back to some normal levels prior to them reaching maturity at 26 or 27 years old, biologically. But if this brain is a 35-year-old brain or a 45-year-old brain and it goes through that type of depletion, we're not positive that that brain is able to return back to normal. So now, again, looking at the evolution and the beginning of this process, let's talk about some definitions. So let's talk about psychoactive drug use and what it is about, at least the definition. It starts out usually as a single episode. It creates a liking for the drug. Now, what happens, y'all, and y'all can write this down somewhere because we're going to go over it again and again. There are three predominant chemicals in the reward system that are activated through pleasure. The first one is dopamine, which a lot of people are very familiar with. The second one is endorphins that we will talk about. And the third one, which a lot of people are not as familiar with, and this is George Koob, some of his long-term research, is the dynorphins. And so in the beginning, when somebody takes a drink or smokes a joint or does a line of cocaine, the brain can create a liking. It doesn't always do that. Some people use cocaine and don't like it. Some smoke marijuana, don't like it. Some drink alcohol, don't like it. But if a person experiments enough with various psychoactive substances, as they do, and as we've seen in a lot of younger adolescents, the brain will choose one. And when it hits one that it likes, it will create a short-term memory. Dopamine, endorphins, and dynorphins. We're going to have several slides on it, Rebecca. But in the initiation of this, in the beginning to sensitize the brain to the drug, one episode takes it, now what that dopamine does, y'all, it creates a short-term memory. Now, y'all know this. How many of y'all like chocolate? How many of y'all like chocolate? Let me see. Amber, Rebecca, Grady, Carmen, yep, Joy, Eddie. Yeah, wonderful. All right, now, let me ask you this question. There's three types of chocolate in our culture. There's three types of chocolate in our culture. There is what we call the medium chocolate. There's dark chocolate, and we have white chocolate, okay? We have the milk chocolate or medium chocolate, we have the dark chocolate, and we have white chocolate. Which one do you like best? You like dark, you like medium, you like white, you like them all. See, it's interesting, and I could go down a list of pleasures for all of you. What kind of music do you like? What color is your favorite color? What's your favorite type of day? Is it cloudy or rainy or whatever? Well, I appreciate it, Angela, for somebody telling me the truth. I like them all myself. But the thing about it is, that brain is going to choose based on your experimentation of it be medium chocolate or dark chocolate or white chocolate, the one that you're going to like the most in the brain, even though it's a short-term memory, is the one that creates the highest amount of release of dopamine at the time that you consume it. And that's memory-wise, it's registered in the ventral tegmentum, the memory system of your greatest pleasures. And it says it prefers, oh, I will eat medium chocolate and I'll eat white chocolate, but I really do like dark chocolate. You understand what I'm saying? And that has to do with the liking. I want y'all to understand the first thing that brain does in pleasure, it develops a liking for that particular drug. Now, just because you use it one time, you definitely can have consequences, as many of you have had if you do any kind of evaluation with individuals who had DUIs. I've had many people who drank I have students who drink for the first time on any kind of consistent basis up here, and they have problems. You can, but most likely, most people, if they have a reaction, it can be physical. For instance, there's about a 7-8% chance of you having an allergic reaction to alcohol. All right, let's see, Eddie. Does setting or environment during the time of use play a role? It can, Eddie, yes. Yes, you can add environment, cues, senses, all of that can add to the pleasurable experience. And some people get involved with that, such as with gambling. It's not just the pleasure of winning, it's the environment of being with this and this and this. Absolutely. But to keep it simple, I'm just going to, the liking is just being exposed to it for the first time. So you can have consequences. Physical, can be physical, can be emotional. As a result of drinking or drugging, it can create depression or create overexcitation, depending on which drug you take. And then you can also have legal or social. You can have a period of a fight. You can have a DUI, as I've had experience with. So just because it's a single episode and there can be consequences, even though they're very rare, but they can be consequences as a result of regular single episode use. Now, talking about abuse, and I love this in the DSM-4 TR criteria, what we have determined by the science is that abuse is a pattern of use. In other words, not a single episode, but people are now starting to use it in a certain pattern. They may be drinking on weekends. They may be drinking every third day. They may be drinking when they go play golf. They may be drinking watching football games, whatever. And it's in which the consumer of the substance in amounts or methods that are neither approved or supervised by medical professionals as it relates to prescription drugs. So we have a lot of people out here who have benzodiazepines and they've been given occasional use, but they will begin to use them without supervision more time than not. And what happens is they can run into some problems, but they're not authorized or supervised by their medical professionals. Substance abuse or drug abuse is not limited to mood altering or psychoactive substances, according, and this is the World Health Organization's definitions, by the way. If an activity is performed in using the objects against the rules and policies of a matter, such as steroids for performance enhancement in sports, it also can be called drug abuse. Therefore, mood altering and psychoactive substances are not only the only types of drugs abuse. We can have drug abuse as a result of psychotropics, and some of you have seen that in some of your patients. They will abuse their antipsychotics. They will abuse their antidepressants. They will do that for other reasons. We definitely have seen it in baseball. We've seen it in football when it relates to the anabolic steroids, and so we call it abuse. Now, abuse also creates the wanting. If use creates the liking and it stimulates the release of dopamine, then we have a wanting, which means there's a pattern of regular use. It creates a wanting. Not only do I like it, but I want it. That's why I want dark chocolate. That's why I want cocaine. That's why I want a cigarette, etc. Now, what this is about biologically is that you have stimulated the dopamine, and then as a result of this, you then create a release of the endorphin system. And the endorphins, now what the dopamine is about, dopamine has to do with pleasure and has to do with perception. The endorphin system, what they have to do with is pain management and the term that we will call reinforcement. Now, we mentioned reinforcement. We have negative reinforcement and we have positive reinforcement. Y'all know that. Y'all know those terms, and we'll talk about those terms in a few minutes. But when we start creating it, the endorphins create what we call the wanting of the drug and the reinforcement. So what this means is every time I drink X amount or use X amount, I'm going to feel this way. That's the memory system that is set up by an individual's brain when they start to use a psychoactive substance. It means that this brain likes this drug at this amount, and it creates this type of feeling. It is called the reinforcement or what the desire it's going to be. Now, the endorphin system is extremely important in creating long-term memory because what it does, it reduces pain. So what pleasure is about, y'all, normal pleasure has to do with euphoria and no pain. That's normal. Euphoria and no pain. That's what euphoria is about. And it has to do, in the psychoactive substance world, has to do with creating not only a short-term memory by dopamine, but also creating a long-term memory as activating the endorphins. So when you release the dopamine, you're also going to release your endorphins. And so that creates this reinforcement. Now, as a result of using on a regular basis for a particular period of time, if you happen to stop abruptly, you can have a physical withdrawal from this particular drug. It can be from alcohol, it could be from marijuana, it could be from benzodiazepines. Not all the time, not in the beginning, but you can create a withdrawal syndrome based on dose. See, the problem with reinforcement is as you increase your dose, you also increase the reinforcement of this particular drug in the brain. And as a result of increased tolerance, you stop taking that amount, i.e. for lack of a group that most people are familiar with, benzodiazepines, you can take them within 6 weeks within therapeutic doses. And even with that, if you stop abruptly, you can create a physical withdrawal. Now, also you can have consequences similar to drug use depending on the amount. So you can have physical consequences, emotional consequences, and legal consequences as a result of that. Now, when we look at a substance use disorder, or what we call addiction, or vice versa, according to the World Health Organization, drug addiction is a state of periodic and chronic intoxication detrimental to an individual and to society produced by the repeated consumption of a drug, natural or synthetic. It's characterized by, 1, an overwhelming desire or need, compulsion to continue to take the drug and obtain it by any means. 2, a tendency to increase the dose. And 3, a psychic, psychological, and sometimes physical dependence on the effects of the drug. Now, what this is when you have this psychic or psychological effect and dependence on the drug and you stop the drug abruptly, it creates the craving. Now, what we have discovered recently about the craving is that the craving has to do with the depletion of the third system, chemical system in the reward brain called the dynorphins. Now, what are the dynorphins, Meryl? Well, the dynorphins, very simply put, is what makes mamas mamas. Women, about 15, 20 minutes before delivery, release these dynorphins. They are estimated to be 100 to 150 times more potent than morphine. And what happens that it, 1, to the mother, it helps relieve the fatigue of the labor, gives her energy for the delivery. 2, it helps her bond to the baby. It also helps reduce the pain of the delivery. I know a lot of women that I've talked to, that may have not always been the case, but we'll talk a little bit about some of those women in just a second. But what happens is the dynorphin system biologically also bonds the infant to the mother. So this becomes one of the greatest living experiences for the mother, but also biologically bonds the infant to the mother. And this is in mammals. And so what we see is this bonding experience. Now, what it does to the mother makes a great experience of being a mother. What it does to the individual from the infant, it gives them the capability of bonding to other humans. Now, what the dynorphins are very important. Actually, it's the dynorphins that create the release of oxytocin, that starts the birthing process to begin with. That's how important they are. But also in the individual, it is what reduces stress relief. It is a stress relieving mechanism. And that stress relief comes from bonding with family or people who are important that you trust. And you've got a great example of that. When y'all have a high stress day, where do most of you want to go? Where do you want to go when you have a high stress day? What is the place that you seek relief from your high stress? The dog? Yeah, I've got one right next to me. Elvis. Bed, home. That's right. Some want to go to the gym. Some want to go to the bar. But let me tell you this. That is where you're going to find your mother's house. Yeah. The thing about it is that is where you're going to find stress relief as a result of the dynorphin system. When you go home, you feel less stress theoretically. So the thing about it is, if we've discovered this bonding component is important in understanding the addiction process, as we've learned it in 2020, of what happens to individuals who develop a substance use disorder. And that's what we're going to about. So we got dopamine, the endorphins, dynorphins, and as a result of definitions, when we have a substance use disorder, we now have a craving, which means we have a depletion of the entire system. Dopamine is depleted, the endorphins is depleted, and the dynorphins are depleted. What does that mean, y'all? What does that mean? What does that mean? Well, when we look at it in the population, we have 50% of our population in the US doesn't use, believe it or not, anything, according to the latest data that we have. The other half develop, and this 50% of that do not use, they can use occasionally, but there's the other 50%, they have some regular pattern of use. We have a high number of individuals to report that say they have a regular pattern of use. And out of that group, 11% of our population, we estimate, and it may be a little higher now, because this is a 2015 survey, develop what we call a substance use disorder. So we have a liking, no problem. We have a wanting, which is not a substance use disorder, but it is a brain changing chemical that begins as a result of regular use. And then as a result of overuse and depletion of dopamine, the endorphins, and the dynorphin system, we set up a craving component biologically, and that is what is involved with substance use disorder. So now, if we look at Koob and Stevens and Ross and some of these scientists that I'm fixing to look at here in just a second, and the definitions of what that's about is that we're going to begin the process of understanding that. Now, I have 1 o'clock, and what we're going to do on the top of every hour, we're going to take a break. So I'm going to escape from the slides a second, I hope. All right. And I'm going to mute it. I'm going to pause the recording, and then I'll be back in 5 minutes. Okay? All right. Thanks. I'm back. So if any of y'all have questions, y'all text me questions. Is 89 cents supposed to be 39 cents? Well, if you take half that do not drink or use theoretically, then you take the other 50%, you would take 89% of that group, and that will leave you with 11% that they indicate may have a substance use disorder, which indicates in their population around 40 million folks or thereabouts. So that's as simple as I could put it. If it's confusing, then I'll see if I can clarify, but I've used that for a while. So that's what I mean by that. So, yeah. Is this helping? Is it making sense? Which part, Eddie? 50% of the population does not drink or use, according to National Institute of Alcoholism and Alcohol Abuse. So we have 50% of the population that does use on a regular basis, according to their report. So out of that 50%, 89% just have a regular pattern of use. There's no substance use disorder diagnosis, at least according to the government. Now, this is in 2015 now. This may have changed since then. We estimate, though, there's 11% of our overall population that has a substance use disorder. So if we look at, let's say we have 340 million, multiply that times 11%, and you see that's the estimate, even though I think it's a low estimate. But for instance, y'all, in the state of Georgia, they estimate that we have about 700,000 individuals who have a substance use disorder, a lot of them because of the opioid use disorder. If I was to add up all the treatment beds, chairs, offices available, you know how many we could treat at any one time? Less than 2,000 people. Now, they also estimate that over 80+% of the population that currently have a substance use disorder will never seek treatment. That's the other reason that I'm trying to do what I do and educating y'all to be better at what you do, is because of that reason. Every one of us in healthcare needs to be a part of trying to understand how to manage and intervene and treat these individuals, because the numbers are overwhelming. And now that we've got the opioid, and of course, a lot of people have minimized the opioid use epidemic. It hasn't changed now. We're losing as many today as we have. The good news is we're resuscitating more because naloxone has become extremely important. I'm going to spend a good bit of the morning tomorrow talking about that. But, you know, the thing about it is we have large numbers of individuals who will never seek treatment. A lot of that has to do, and I've got a new study going on currently in Georgia about indigent care, about how many people do not have resources or access to care as a result of that. So that is, I think, important. So, all right, I got 5 after. I'm ready to start back, everybody. So when we look at the neurobiology of substance use disorders, and continuing with Dr. Ross's definition, he said enhanced dopamine transmission in the nucleus accumbens as a part of the common pathway for positively rewarding aspects of drugs of abuse and the initiation of the addictive process. Gamma aminobutyric acid, opioid peptides, serotonin, acetylcholine, the endocannabinoids, and glutamate system also play a role in the initial addictive process. Dopamine also plays a role in the conditioning responses to drugs of abuse, and addiction is now recognized as a disease, and now I wanted you to underline this, of pathological learning and memory. It is a disease of pathological learning and memory. In the path from substance abuse to addiction, the neurochemistry shifts from a dopamine-based behavioral system, which means a reward-based system, to a predominantly glutamate-based, one marked by dysregulated glutamate transmissions from the prefrontal cortex to the nucleus accumbens in relationship to a drug, to drug versus biological-oriented stimuli. This has been called the anti-reward brain. Now, what they're saying here, y'all, is that we have this balancing act, that we have a pleasure brain, a reward brain, which is whoopee, and we have a pain brain. Ouch, whoopee, ouch, whoopee, ouch. And the central nervous system in normal brains tries to put us in the middle. So instead of feeling pleasure or feeling pain, we're just okay. But as this type of research and other research has indicated, as a result of overuse, high amounts of dosaging, long-term use, it creates a depletion in the reward centers where the dopamine is depleted, the endorphins are depleted, the dynorphins are depleted, and what you're left with is this predominantly glutamate-based or this anti-reward pain brain. So people who are coming in with substance use disorders have many, many characteristics, but one of them that is common to all is the acknowledgement of pain. Addicts are addicted to pain, not pleasure. And I say that simply in that that brain becomes pain-based only. Y'all, it is an anti-reward brain. What that means is not only do they experience pain, but they cannot experience pleasure. They come to you in their first assessment and they're argumentative and they're angry and they're afraid and they blame people. And it's because the brain has no chemistry to allow them any kind of pleasure from the experience of trying to get help. And that is what we call the anti-reward brain. And that is what 95% of healthcare professionals do not know or understand. And it's biological, y'all. It's biological. It is predictable. And that is one of the things that is overwhelming to the individual as well as it's overwhelming to the practitioner. There is a core of the executive dysfunction that now is understood as the hallmark feature of addiction that also includes impaired decision-making and impulse dysregulation. Now, let me talk about dopamine. Dopamine in the prefrontal cortex controls impulse dysregulation. It also, dopamine in the prefrontal cortex motivates an individual to create. That's one of the things that they said. It creates that process that pain can be something different. And I think Eddie's talking about pain is pleasure. Pain can be pleasurable if it's reversed. See, the thing that has to happen though, Eddie, is the person has to experience enough pain in order for the dysregulation of the brain to rewire the circuitry. So instead of getting pleasure out of something rewarding, they get pleasure out of something that's negative. That's what we call abuse. That's why domestic violence is so addicting. Individuals in a domestic violence situation become addicted to that pain, which in the brain can be registered in some level of pleasure. Do you understand? It's a complicated paradox. Understanding your biology of the addictive process allows for theoretical psychopharmacological approaches to treat the addictive disorder. Now, with that said, y'all know better. There is not one medication that can manage pain. There's not one medication that can manage all pleasures. One has to take into effect the account of biological interventions at particular stages of the disease. And that's the thing. So this dopamine that is necessary for controlling impulses and compulsion, it also creates hope. That the dopamine is, it says, I want to live, I want to get out of bed, I want to go do something different. What happens when you deplete that dopamine, it also increases the risk of suicidality because people become desperate, in despair, hopeless. And of course, as y'all well know, we have such a higher risk of suicide as a result of substance use disorders. And that's one of the things. So here's kind of my cheat sheet. Well, I'm going to try, y'all forgive me, this mouse of mine is creating some problems, creating some pain for me at the moment. So if we look at dopamine, it's in the pleasure brain, it's in the reward brain, it's responsible for positive reinforcement. I call it the accelerator of pleasure. In other words, it's a stimulant, so when we push it, we go. And what it does emotionally, it creates like. As a result of it creating like, and it combined with endorphins, it creates want. And this can happen in relationships as well as drugs and other behaviors. And as a result of stimulating dopamine and endorphins, you stimulate dynorphins, and it creates biologically what I believe is love and nurture. That's why we get mother's love and those types of things and the way we feel about our mothers. So that's dopamine, that's the accelerator. Now in the brain, also we have the regulator. We always looking at homeostasis, that the brain doesn't have a lot of dopamine, so we can't overuse it. So we have glutamate. And glutamate regulates the pain brain, or what we call the anti-reward brain, which is negative reinforcement. And I call it the brake of pleasure or pain. And when we break pleasure, it can create depression, anhedonia, and craving. So we have these two systems, the accelerator and the brake. Whoopee, ouch, whoopee, ouch. And the central nervous system's job is to keep the brain in the balance between the two. So we're just okay, as I keep mentioning. That's the regulation component. Dopamine, endorphins, dynorphins, glutamate, GABA, substance P, all of those things involved with pain are part of the breaking of the pleasure. So it's a balancing act. It's a big balancing act. So now, as a result, we kind of have these different levels of brain, and you have the use of the cortex. And then we have the abuse area, which we call route the developing. It comes out of the midbrain. And the midbrain is responsible for what? It's responsible for personality, it's responsible for perception, and other types of activities. And that's where, if you use on a regular basis, stop abruptly, you can have increased tolerance and you can have physical withdrawal, but that is not a substance use disorder. That just means that you can have what we call physical dependence. And a lot of people can become physically dependent. Well, everybody can become physically dependent to most any controlled substance that I have on my list in the pharmacy if they use long enough and we stop it abruptly. They develop a tolerance and can go through a withdrawal. But when we talk about the midbrain and when we look at what we call dependence from a DSM-4, these are DSM-4 definitions, it has to do with the involuntary instinctual reward centers. And that's been known for 20 years. And so we have these different approaches to do it. Now, for the longest time, dopamine has been thought to be the primary chemical in substance use disorders. And y'all know that. Y'all probably all know that. We call them dope addicts because they're addicted to dopamine. That's why they call them dope addicts. But the thing about it is, so what is dopamine's primary purpose? Well, we've mentioned this already in several ways. It's all drugs of abuse and potential compulsive behavior release dopamine. It's the first chemical in the cascade, dopamine, endorphins, dynorphins, generate a rewarding experience. It is important for salient or survival importance, which we mentioned. It gives hope that I'm going to get up in the morning. I wanted to go do something. Dopamine is more about wanting when it stimulates the endorphins than liking. So if we use on a regular basis, we have a reinforcement component. So the brain begins to choose what we like the best. If it be blue, red, purple, yellow, black, color, jazz, rock, oldies, those types of music, it because we've experienced that, it creates the release of the endorphin. Dopamine is more about expectation than consummation. Now, in the brain, that VTA, it sets up the expectation of what it is. That's why so many individuals who suffer from substance use disorders, and I've talked to thousands of them, will always remember the best high they've ever had. They will grin about it. They will smile about it. I've seen them in assessments. I've seen them in group therapy. I've seen them in aftercare. I've seen them in all different levels. When they start talking about, they start smiling, even though the consequences of their use was they lost their job, they lost their family, they were incarcerated, whatever it may be. It has to do with more about expectation than consummation. Dopamine signals reward prediction error. When something is better than expected, it anticipates, it creates that anticipation of, oh, this is going to be great now. And again, we have all of that. We live by that. I don't know where you all are living, but I'm sure at some moment in time, and this is no reflection on anyone, y'all have bought a lotto ticket. And what is the lotto ticket for? It's in our brain that for whatever reason, we were able to win the lotto. What would it be? It would be better. Things would be better. And in reality, that is not always the case, as we know, because most of those individuals, after they win it, because they had that surge, tremendous surge, they spend many months in a very depressed state, especially when they're done something compulsively, like spend all their money. A lot of people end up doing that. That has to do with the sensitivity to the signals in dopamine. So dopamine and nucleus accumbens, it does more than encode the receipt of reward. It has the expectancy of reward. So that's what happens in this brain that changes. If I use cocaine, this is what I can expect. This is what, this is what I anticipate. It gives me the amount of reward. Now, the greatest amount of reward most of us are going to have, it's like eating our chocolate. Now, y'all go back to our chocolate. Now, some of you may have had some chocolate at the break, or you may have chocolate with you now. But the thing about it is, I haven't had chocolate. I'm on this real specialty diet because of my lovely bride, and we've decided we're going to get healthier. And of course, I don't know if y'all know this, but my wife suffers from late stage 4 non-Hodgkin's lymphoma. And we've had a lot of chemo and a lot of work this past year in order to get her back to some sort of normalcy. And I'm very grateful that she is. But one of the things that we have to eliminate is high amounts of sugar, which she was a carbohydrate individual. So, but I love chocolate, but I'd had it in a long time. But if I was to have some, ooh, it'd be good. But what if I had that chocolate every day and high amounts? What happens is, y'all, we deplete the dopamine. And so our pleasure from that diminishes. Dopamine is also the delay of reward. There's a part of us biologically, because of the brain's capability of wanting to reserve dopamine for certain moments, it will delay reward. And so it works in that way. Errors in reward prediction, we've talked about motivation for drug seeking. It contributes to the synaptic neuroplasticity that underlies the acquisition of addictive behaviors. They say, and many of the neuroscientists have said, the more exposure we have to dopamine, the higher likely it is for someone to develop an addiction process. Because dopamine is not to be, our brain is not used to being exposed to dopamine. You know that pleasure in our brain is not necessary for survival? Do y'all know that? It's not necessary. But the thing about it is, if we expose the brain to too much dopamine, theoretically, as they're talking about here, Garner and others, they say it changes the neuroplasticity of those pathways that can lead to substance use disorders. Now, Norvo now, who's the director of the National Drugs of Institutes of Drug Abuse, has spent her career studying dopamine and its effect on the brain. She has done PET scan studies, she did fMRI scan studies. She looked at the overlapping of the brain circuitry underlying addiction, such as binge eating, pathological gambling, sexual compulsivity. And along with that, she's also looked at these other chemicals that are tied to this, such as glutamate and GABA and the endogenous opioids and cannabinoids. And we'll talk a lot about cannabinoids this afternoon, that I want y'all to hear about the new news about the cannabinol stuff. But the thing about it is, Dr. Bonal has done that research. So here's your question to wake y'all up now. The drug that causes the greatest release of dopamine reward in the brain's dopaminergic system is A, alcohol, B, benzos, C, cocaine, D, marijuana, E, methamphetamine. Yep. E, absolutely. E is the answer. And I'm glad that y'all have that. Now, this is part of the study. Let me see if I can, let me back up. So when we look at this, and this is a study from 97, replicated in 2003, and I think again in 7, and these are animal studies. They say, for instance, food, we set when we're empty and we don't have any food on board, we have a dopamine residual reserve of about 100. Now, as that 100% begins to diminish below 100, we get hungrier. We begin to seek feed. We have an opportunity to seek food. And what they say is that when we hit that and we start feeding, as most of us do, then what happens? We begin to have some release of dopamine. And most of us know that in our culture, food is a big deal. We have gone to lighter foods and healthier foods, and I'm drinking almond milk and doing organic yogurt and lots of fruits and vegetables. At lunch, I will have a very nice salad and water and all these things. But the thing about it is, as we get hungrier, we eat, our dopamine will increase. And in this slide, it says, when we get satisfied, theoretically, it hits 150%, which we have great pleasure when we finish and we say, that was a nice meal. If we look at thirst, and I don't have that slide with me for the sake of time, it would be 175. So when we get thirsty, we drink, we get a 175. If we had sex, and it's one of our greatest experiences, it registers about 200. So 150, 175, 200 are the natural experiences of pleasure from dopamine release, because dopamine doesn't want to go over 200, because that way it has to increase its factor capability. It increases sensitivity to the pathway in the brain and also to the cells in the brain. And that could become an addictive process theoretically. So the brain limits its greatest experiences to 200. It is only when humans begin to take substances of abuse, psychoactive substances, uppers, downers, all-arounders, and they begin to increase the dose. So when we look at, for instance, the amphetamine slide, this is actually methamphetamine. One dose of methamphetamine will increase the dopamine levels almost 1,000%. One dose. 5 times that of sex, 8 times that of food. So you can begin to see very rapidly, even with one dose, the tremendous change the brain goes through. Now, if that brain begins to use on a regular basis, guess what happens to the normal desire for food and the normal desire for sex and the normal desire to quench thirst? It diminishes. Also, when they hit that 1,000%, as I said earlier, that's the highest high they will ever experience in their lifetime. Next time, it's going to hit 900%. And the time after that, it'll hit 850. Do you understand? Even though the brain will register 1,000%, the anticipation is, I'm going to use this and it's going to hit 1,000%, but now it's only going to be 850. So guess what happens? People say, well, I'm not using enough. So when they're not using enough, what do? They increase the dose. Thinking the dopamine will increase. Guess what? It doesn't. It creates a further diminishment in the dopamine. So they hit, and so that's why when people take hydrocodone, which is a normal dose of hydrocodone, is anywhere from 20 to 30 milligrams per day for a short period of time. My last opioid use disordered individual who was addicted to hydrocodone was taking 600 milligrams a day. because of the increased tolerance and the increased thing as a result of that. So that's where the dopamine changes, y'all. Now, in order to try to offset that deficiency in the dopamine circuits, the brain activates, again, the endorphins in order to supplement the dopamine, not just for reinforcement, but guess what it does? It creates higher reinforcement in the brain for that particular drug. And so that drug becomes the drug of choice for that brain because of the release of not only the dopamine surge, but also because of the endorphin surge. But the brain still has that expectation of 1,000, but it's only at 700 now, and it's starting to deplete the dopamine, and they keep using. It also creates a deficiency in the endorphin system. And guess what, y'all? The dynorphin system is the granddaddy. It tries to come in, and what we know, it tries to replace and replenish endorphins, and also tries to act to replenish the dopamine in order for the brain to reset itself, but it doesn't have and it cannot change the memory of the greatest experience. And so the individual continues to increase the dose, increase the number of times they take it. And by the time at the end of the road, y'all, they have depleted the dopamine, they have depleted the endorphins, they have depleted the dynorphin system, and the brain is out of control. It doesn't know what I'm going to do. And the dynorphin, what it does, it creates a detachment from human relationships. And so the individual inside of the family withdraws from the family, doesn't want anything to do with the family. And on top of that, y'all, on top of that, it diminishes the bonding component of that humanality. And the brain is trying to seek stress relief. So what it does, it simply is hijacked, and it seeks the stress management relief, not from the dynorphin system, which is now deficient, but it seeks it from the drug of choice. And once that hijacking takes place, it is forever. So anytime from that point on, that brain has high stress moments, positive or negative, guess what? It activates a craving mechanism. And it is forever bonded most intimately with that drug of choice. That is what we know about the dynorphins today from Dr. Koob's work and others. Now, so we have all of these dopamine releasing chemicals. We won't have time to discuss them except this afternoon. Hopefully we'll get through some of them. And we have all these dopamine releasing behaviors. And some of you have already reported that it makes a difference. And some are addicted. I have pharmacists. I've treated 1,200 pharmacists in my career, and 300 physicians and other folks. And my pharmacists, they were involved in gambling. A lot of them were involved with gambling. I have my physician involved with food. I have a lot of, some of them, and a percentage of them with sex and dysfunctional relationships. So we have all of these types of behaviors. And this is the spectrum, the generic spectrum of what we have. And so it's one of those things that we have both chemicals and also behaviors that activate similar systems. And so here's dopamine. We've talked about the dopamine. I'm not going to spend a lot of time with that because we've already gone over it, but it's a very simple molecule. It's a stimulant. It does create that. In the world that we look in, it has comes from tyrosine, L-dopa, dopamine. That's why it's extremely important in the treatment of Parkinson's and other neurological components of movement disorders. We also have a depletion of it in the peripheral nervous system, and that's what creates a tremendous amount of the withdrawal phenomenon in certain psychoactive substances that we have to manage through detox. And so there's the reuptake system. And so what we have is that little star on there. And that's what we see from this standpoint. And this is a NIDA slide. Some of y'all have seen this. So as again, satisfying hunger elevates dopamine about 50% above the norm. In other words, it goes up above that. Satisfying sex elevates dopamine about 100%. It goes up to 200. Hunger's 150. So that lasts 36 minutes. Sex can last a few seconds to a minute above that level when we talk about orgasm and those types of things. Normal And then nicotine, for instance, why do so many people smoke? It elevates dopamine up to about 225, which is 125 above 100. Morphine, which I'm a pain management specialist, elevates dopamine based on a normal 5 milligram dose up to 100% per dose. So what I'm going to do is somebody's on morphine and they're coming out of surgery, I'm going to put them on a PCA pump, and I'm going to calculate the loading dose and the maintenance dose, and I'm going to try my best not to allow that morphine to go over 200% over the time that they're on it. And then even with that, I'm going to decrease the amount before they're discharged from the hospital so they can be placed on a PO med going home if necessary. But it's 100%. Anytime people take a dose above the prescribed dose, they increase it another 100%. So it goes from 200. And so you take in 10 milligram hydrocodone, it's a 200. And then somebody says, I'm going to take another one. It's another. So it goes up to another 200. So it goes 200, 400, 600. You see very quickly how people can become overly involved with that. Methamphetamine, as I showed you, can go anywhere from 100 to 1100 above the norm, which is tremendous amounts of by one drug. At the same time, it creates CAMP, and we'll talk about CAMP in the BDNF system. It creates energy, and also it creates compulsivity. CAMP is the energy in the neural system that activates certain neural pathways over time. And it's tied in with the BDNF system that we will talk a little bit here shortly. But the thing about it is, why most people, even with opioids and even with alcohol, there seems to be some possible genetic malformations that occur in the brain that doesn't cause most people who take opioids get sick or sedated. About 40% of individuals, they stimulate certain chemicals in the midbrain region that creates energy. And they'll tell you that it created energy in me when I took my first hydrocodone or oxycodone. And that's how people, because of this increased CAMP, create the process of substance use disorder as a result of that. Now science has discovered that there are many other neurobiological pathways involved in substance use disorder, many others. And so we want to see about those. Now, self-assessment question 8. The most abundant neurotransmitter or neurochemical in the brain is A, the endorphins, B, serotonin, C, epinephrine, D, glutamate, E, dopamine. D. It's, as I've already told you, it's glutamate. It is one of the ones, and the reason for it is our pain, our brains are wired for pain and not pleasure necessarily. Pleasure is there, but we are wired for pain. And because it is self-preservation, as this Neo Geographical article talked about, is pain is for self-preservation. It is to let us know that when something's wrong. And so when we look at glutamate, it is definitely the most abundant, according to the science. It's critical in memory formation and consolidation. All drugs of abuse and many addictive behaviors affect glutamate, which preserves drug memories and creates drug cues. So I think several of you were mentioning about the environment. Does that have a part with increasing the euphoria? And the answer to that is no. In the beginning, it increases the enhancement of the thing, but it is glutamate that really, once a person becomes addicted, creates the drug cues because the brain doesn't have any pleasure. Glutamate permanently reinforces negatively what that individual wants to go do to drug seek. And this whole thing has to do with motivation. Why are individuals, and I'm in a intensive outpatient program at 6 weeks. It's not very long, but it's about 25 hours a week. And you can put them in there and remove them, detox them, and treat them. And they can go to a group or they can go out and be discharged. We offer a year aftercare, and within 3 months, they're back doing the same thing. And they said, my buddy came by who was my dealer, and he was drinking a beer, and I said, well, I'm not addicted to alcohol. I'm just addicted to opioids. And so I had a drink, and next thing I know, I was taking oxycodone. the motivation component of glutamate is overwhelming. And we'll talk about how that comes about. Glutamate is also the pain brain's master regulator. Glutamate starts the pain cycle and the cascade for pain, and it's hugely important. Now, I won't spend a lot of time with this. Simply want to use this slide for dopamine is go, and glutamate is stop. Go, stop. Whoopee, ouch, whoopee, ouch, whoopee, ouch. And the thing about it is, it's the accelerator. And let's put it in perspective. Dopamine stimulation, at least in some of the models, lasts a few minutes, as I mentioned to you earlier. But pain, as a result of it being a primary and it is an organizing function of the brain. It wants to have some attention that something's wrong. Pain can last for hours and days, weeks, years, depending on if it's acute or chronic, of course. So the thing about it is you have these two drives. One's extremely limited, very important, dopamine, and one is hugely important for survival, pain. And so you've got the balancing act between these two. And so it's one of those things. So we look at impulsive behaviors, and we all have them. They usually are triggered by stress. And it can be, I see my students when we have an exam, and I don't know how y'all do with your exams, but I have my students, they've got an exam coming up on Tuesday, and it's their first exam of the semester. And so they get in all, you know, what can I study, where, blah, 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 all get real compulsive in order. And I see them roll their pencils and pull their hair and scratch their nose and all kinds of things impulsively. And it's a normal process to help the individuals manage stress and offset this anti-reward brain. And what we know is it creates positive reinforcement. And that's what impulsivity is. It is a positive, it actually shuts off the anti-reward brain for a short period of time, the impulse component of this. And so it's normal. A lot of us have it, all of us have them. It's just, it is something that we need to do because there's a balance between reward and pain. There's a balance between dopamine and glutamate. You understand? That's why we have it. Now, Peter Cavallis, who is over in the Medical University of South Carolina, said that he came out with, there's a spillover of glutamate that they've discovered in the last 4 or 5 years. And he says that excess glutamate spills out of the synapse to being to extrasynaptic glutamate receptors. Now, what happens, y'all, when all of that technology happens in the pathways, it actually stimulates more release of dopamine. So when you're using pleasurable drugs and they're creating dopamine, you're going to have a release of glutamate that's going to naturally try to break the amount of dopamine being stimulated. Dr. Cavallis says when you're using high doses of psychoactive substances, that excess glutamate will cause a spillover or overstimulation of dopamine. So what it means is when you're taking higher than normal doses of alcohol or marijuana or opioids, guess what? You're going to overstimulate the dopamine more than usual. What that does, y'all, it creates a faster depletion of the dopaminergic system. And what that creates, y'all, is a depletion of the system, and that creates negative reinforcement. So when glutamate is overstimulated, a spillover by drugs of abuse, it causes further dopamine release, thus enhancing the depletion or pushes the accelerator harder. When the dopamine is depleted, the brain becomes more compulsive and begins to activate the anti-reward brain, pain brain, and releases more glutamate. This is negative reinforcement. The brain tries to reset itself to homeostasis by activating the craving cycle to seek more dopamine. And if I was to put another sentence in here, I would say the individual takes more of the drug of choice, which creates further stimulation of the glutamate and further stimulation of depletion of the dopamine and enhances the negative reinforcement. So are most people who suffer from substance use disorders happy, joyous, and free? No. The ones I see sitting on the couch getting ready for an assessment or an evaluation are not happy to be there. They're not grateful to be there. They don't want anything to do with their families. They usually don't want anything to do with anybody around them. All they're interested in is returning to use. And this is the reason for it. That brain is wired now for negative reinforcement as a result of the changes in dopamine, the endorphins, and the dynorphin system. Okay. Now allow me to add one more little piece to this. There's, and some of you may be familiar with this, there's some transcription factors, the false Bs, that we've discovered. D false B, we've discovered on 11, 12, that the researchers say it increases drug-seeking behavior. Now, what D false B is, it is a, has to do with structural plasticity induced in nucleus accumbens. And we studied, and this particular study has to do with cocaine. Now, the nucleus accumbens is where we experience pleasure. It tells us the kind of pleasure we have. And so what happens is, it is important that we have enough dopamine present in this system. Now, what happens as a result of using psychoactive substances and you increase the dopamine, which creates the increased release of the glutamate, you also secondarily, we believe, increases D false B. And what that does is create what we would call a memory chip along the dendrites in the nucleus accumbens that respond to dopamine. And what it does, the D false B, and there are other transcription, I think there may be 50 or 60, there may be thousands of these. What it does is it puts that memory chip within those dendrites inside of the cells of the receptors of pleasure and dopamine, and it simply reinforces the effects of what the pleasure should be, but also it says, if you don't give me the same amount that I had the last time you gave me the dopamine release. So instead of taking 30 milligrams of hydrocodone, I'm taking 600 milligrams of hydrocodone. Guess what? It creates a tremendous diminishment in activity that activates, and we believe, y'all, we believe, now this is just theoretical, this could be the biological components of craving and drug-seeking behavior. So, what do we want to create in pharmacy? We want to have a D false B antagonist. We want to have a D false B antagonist that could be used to offset this relapse, what we call the relapse chemical in the brain. Now, how do we do that? How do we do that? How do we do that? Do I have a drug that does that? No, not at the moment. We just discovered this. I don't have a drug to do this. We've got other things. But what I'm trying to tell you is, you see the multiple layers of dysfunction that occurs in the brain as a result of the changes here. So in my simple way of putting this together, I put a brain together. And it has to do with the prefrontal cortex and has to do with other things, and I'll see if I can get this to work. I have the thinking brain that includes the prefrontal cortex, and that's the judgment brain. And then we have the instinctual brain, which includes the nucleus accumbens, and that's the pleasure brain. And so we have these prefrontal cortex, nucleus accumbens, ventral tegmentum area. That is the reward pathway. And so what we see in the normal positive reinforcement brain that has some impulsivity to it, but no compulsivity to it, we have them, first thing is people will say, I want a bear. Activates the prefrontal cortex. And from that prefrontal cortex, it will go down to the nucleus accumbens. And why does it want a beer? It makes me feel good. So I want a beer. It makes me feel good. Creates that positive reinforcement. And then as a result of that positive reinforcement, it will go over to the ventral tegmentum areas I mentioned to you before as a result of releasing the reinforcement, and it will simply tell you, Miller Lite. It has a preference. It has the greatest experience, the alcohol that it creates and likes the best. So normally it would be, I want a beer. It makes me feel good, Miller Lite. And that is how people use psychoactive substances on a normal level. And they stop, and they don't have compulsivity to return to use necessarily. So now the addicted brain is actually almost opposite to this. So it is a negative reinforcement brain, which means it not only has a depletion of dopamine, but it has excess glutamate due to the spillover of the activated dopamine and spillover according to Dr. Cavallis. So what happens is, as I told you earlier, this brain, as a result of depletion of dopamine, the endorphins and dynorphins, has no stress management capability. So when this brain has a stress moment and it is now addicted to a certain drug that is now the stress manager, guess what happens? The brain has any stress, the first thing that happens is what? Miller Lite. It makes me feel good. And that's your craving. Involuntary, automatic, instinctual. It can occur at any time, any stage of recovery, even though we know that long-term recovery, people have developed skills and developed components to a recovery mechanism that they can manage when these things hit. But even still, y'all, we have this. In early recovery, they're very, very common. That is why we have the anti-craving medications, such as Campril and naltrexone, Revia. We even use Antabuse now as an aversive therapy in order to offset this. Now, once this craving, which is instinctual, automatic, and involuntary, once it starts, if there's no prefrontal cortex control, which is kind of what treatment is about, what the treatment components, and we'll talk about these tomorrow, does biologically, we believe. It's very similar to what occupational medicine does in people who have had strokes. If you repeat the same activity through the same process over many days, many weeks, many months, you create new biological pathways that begin to reopen. And for instance, if a person is paralyzed on the right side and they put the ball in the hand, they start squeezing that ball, and over several weeks or months, that hand begins to move again because they've created a new pathway. Same way in the recovery process, except it's behavioral. This is what y'all are experts at. Y'all are behavioral. So what you have to do, you have to repeat everything. It's kind of like neurolinguistics. You see it, you do it, and you repeat it. You hear it, you see it, you do it, you hear it, you see it, you do it, you hear it, you see it, you do it. And what that does is create neural pathways up in the prefrontal cortex to manage the craving. So you don't drink or use, you find and go to a meeting, you find and call a sponsor, you work a spiritual program, you repeat daily. The components that are taught through generic different phases of ASAM level treatments, but they've done it repeatedly over time, in order to do what? If they have the craving where it says Miller Lite, it makes me feel good. If there's no reconfiguration of the prefrontal cortex where people have a skill set to manage the craving, then guess what happens? Guess what happens? I want a beer returns, and they can return back to the behavior. Relapse occurs. And so we're trying to control instinctual pleasure brain with the judgment brain through a set of cognitive behavioral activities and other types of approaches that are used in group settings, individual settings, mutual help group settings, other things in order to manage this instinctual component of what this brain is about. Because we've got to readjust it's kind of like in graduate school. Y'all remember in graduate school being a major professor in graduate school for several PhDs. My first year with them, a lot of them I had to untrain what they had learned in order for them to train what they needed to know. Y'all have gone through that, I'm sure. Through experience, through research, through academics. But that's what we see here in this brain. Now, when I look at the next, and that's kind of the generic overview. When I look at the next group, we're going to look at the BDNF system. And what did I tell you the BDNF system was? What did it regulate? What's the BDNF system regulate? Anybody? Mood. It is the regulator of the mood, we think. So what we have in the BDNF system is a set of chemical messengers, and they are connected to electrical circuits, chemical circuits called CAMP. And that's the chemical that connects the messengers with the CREB, which is what I call the transformers, which converts the electrical messages to chemical messages and the chemical messages back to electrical circuits. So you have a very complicated system. And so in the world that I live in the world that you live in, addiction or substance use disorders in 2020, as it was in 2019, equals depression. And the reason for that is the first thing that you implement when you start to use a psychoactive substance that we've discovered is you change the BDNF, which changes the mood. So your CAMP is your cyclic adrenal monophosphate used for intracellular transductions. BDNF, brain-derived neurotrophic factors, encourages the growth and differentiation of new neurons and synapses. It's a chemical component. And CRB, which is CAMP response element binding, creates neuroplasticity and long-term memory formation in the brain, transforms, converts electrical messages to chemical messages. And so what happens, y'all, all of this changes almost the first time somebody drinks or uses. And you know that. That's why it's called a euphoric. You change the BDNF, you change the mood. Now, most people get happier or more pleasant, where some people, guess what? They go the opposite way. And it has to do with the BDNF. So here's the DSM-5. I won't go through this for time reasons. You can review it. Y'all have had it. You've got a handout. But you basically, what they did in the DSM-4 TR, they combined substance abuse criteria, which they were 4, with 6 of the DSM-4 TR use disorder, dependence disorder, or dependence definitions. And then they added 11th one, so they made 10, 4 and 6 made 10, and they added a craving. And so now they have 11 different criteria, more criteria than I've ever seen in one particular one. Yeah. They also have severity levels. Now, what I want y'all to do in your cases is, once you look at these cases, I'd like for y'all to give a shot at, based on the number of criteria that each case meets, what criteria they meet. Is it mild, moderate, or severe? and I've tried to make them differentiate some, and y'all have had experience. Some of you had experience, some of you may not, I don't know, but it gives you some example of you looking at the criteria and how it fits into each case. And so that gives me an idea. Most people, based on availability of treatment, don't have the 7 levels of care in ASAM. They have 3 or 4. Based on resources, they may only can afford 1. So mild, moderate, severe. So list your criteria according to how many. 2 to 3 is mild, 4 to 5 is moderate, 6 or more severe. Now, just FYI, when we look at BDNF and moderation, they have discovered in a study or 2 recently that when they reviewed it and they look at the brain neurotrophic factor and alcohol, there's some evidence that says when certain BDNFs are appropriate, signaling acts to keep alcohol drinking in moderation. In other words, the BDNF tells you, I don't want to be depleted, stop drinking, and the brain stops, and the person stops. So when we have those brains that do that, we tend to have that. And so we will do that. So BDNF is pretty important as far as we think maybe. And so what do we want to do? Do we want to get a moderate? Do we want to get a BDNF agonist? Yes, but it's most likely going to be an MAPK dependent type of agonist that may help us. And again, we look at, again, the genomic component to this and how we tie a drug molecule to a genomic component of the person's DNA. And that's where we're headed, y'all. That's where we're going with the management and being able to manage and actually possibly at some point be able to cure. I don't know that we will say that word here, but we may be able to do something down the road with substance use disorders, especially those who have significant ones. And the ones they're looking at closely right now, of course, is the opioid use disorder. So here's your question before we take a short break. Trauma impairs the brain's information center much slower than psychoactive substances. A, true. B, false. Y'all agree? Correct. B, much faster. Much faster. So what we're going to do, and come back in just a minute or 2. I don't even think I'm going to turn the audio off. I'm going to let it run a minute. We'll come back and talk about the effects of trauma on the brain and substance use disorders. Okay? All right. Be back in a minute. Y'all can take, just tell me when you're back. Just tell me back. I'm just getting me a bottle of water. Okay. Just tell me when you're back, you know. I want this to be as enjoyable as possible. If we need longer, I can do that. Thanks, Aiden. Appreciate that, Aiden. All right, Brady. Y'all back? Everybody back? Anybody else? Well, I'm impressed. I can't believe I almost got 100% attendance. This is great. I'm very happy about that. Okay, let's see if we can move on and get to lunch or brunch or wherever you may be. And let's talk about trauma a little bit. And again, I'm going to speak from it from a neurobiological standpoint. And the effects of trauma, Abraham Maslow has said, if all you have is a hammer, then all your problems are nails. And he explained that. And so I'm going to try to help give that some insight into what we do when we look at trauma. Alexander McFain said, because the stress response disrupts general information processes, survivors of trauma live in a somatic world rather than a world of language. And again, in my world, most people don't know what you know, and I'm very happy that we won't spend a lot of time, but it's extremely important to know that trauma and addiction causes brain changes in the brain's functionality and neurochemistry. Both trauma and addiction activate the anti-reward brain system, which is operated by glutamate, GABA, and other pathways. Both trauma and addiction deplete and shut down the reward system and operates by using primarily dopamine, endorphin, and serotonin, along with the dynorphin system. So we know that it creates some significant problems. Both trauma and addiction are activated by the stress response. Primary difference is trauma can change the brain within seconds. Addiction may take months or years. The thing that we do know is recovery from trauma and addiction takes really a lifetime of effort. And I have many patients over the years who've had extreme trauma from that standpoint. And we'll talk a little bit about that. Now, as we see the cycle, that trauma creates the emotional upheaval, and a large majority of people, as a result of that emotional upheaval, either to manage the stress of the situation or the pain of the situation or the memory of the situation, or all three, use substances, psychoactive substances, which minimize some of that. Does not eliminate it, but minimize it. And what we know about that, it decreases the ability to learn new skills and process traumatic material. We do know that depending on when that occurs, you have a child who suffers significant trauma at 5 years old, the brain has significant damage that occurs that may be irreparable. We have a child that has significant trauma at 14 or 15 years old. It can create the same type of process, but because the brain is a little more mature, we have some hope that we can at least repair a lot of that. And we have a brain at 40 years old that has that damage. It may not recover. We have combat individuals, 18, 19, 20-year-olds that suffer significant emotional, physical trauma, and they have that injury that occurs as a result. We work very hard and have come out with some very good approaches to manage and help them learn to manage the dysfunction in there. But a lot of them have turned to substance abuse to other, and what that does is shut down the capability of them being able to be teachable from that standpoint. So we have a pretty vicious cycle that we have to intervene on. Now, chronic stress, severe stress increases CRF. And when you increase corticotropin releasing hormone or factors, you decrease dopamine at the D2 receptor. And D2 receptor, there's 5 receptors in the brain of dopamine, we know. D2 is kind of the euphoric component of that. And so what happens as a result of increased stress, decreased dopamine in the D2 receptors, you have anhedonia. And then what the definition is, at least the ones I've heard that I like, it's pleasure deafness. The patient is no longer able to derive normal pleasure from those that have been pleasurable in the past. And we see that many times. We see that many times of individuals. That's why trauma impairs the person. I have dealt with, in my forensic world, I deal only with death cases, and my last several cases have been murder cases where a death of 1 or 2 or possibly 3 family members, and the impact that it has on the surviving family members as you see them in that courtroom and hear all of the stuff that goes on and look at what has happened to them. You see those types of things as a result of that. And a lot of them, and my last recall of my last court appearance, they had 2 that were highly intoxicated coming into the courtroom, and they had to be removed because they could not deal with the pain of having the slides and all the things that they present in court. And a part of that was them to overcome some of that anhedonia that they were creating as a result of that traumatic experience they suffered. Now, when we look at anhedonic deafness, there's some psychodynamic self-medication hypothesis focuses on the underlying development difficulties, emotional disturbance, structural factors, building of self and personality organization. Individuals are hypothesized to take drugs as a means to cope with painful and threatening emotions. So people do that. And then the people who have comorbid psychiatric disorders, and we've seen this probably more often than not, there's some strongest association are found with mood disorders, antisocial personality, and conduct disorders as a result of trying to feel somewhat normal. So we have both sides of this coin. Now, when we look at the stress as it relates to substance use disorders, one of the strategies that has to be looked at, and these are multiple strategies, but when we look at the research, the interesting thing is, and some people may or may not expect this, one of the first things that we look at from having to reduce the stress of an individual with a substance use disordered brain, safe housing. Safe housing. That is extremely important. And we want to know why. It's because, y'all, I told you about the dynorphin system and the deficiency we have in there. I have no drugs, no medications that enhance dynorphins. The only way that I can enhance dynorphins is through a behavioral process. And what that does is, if we deplete the bonding of most capability of the individual substance use disorder, the way that we reinitiate that process, and we have to build the pleasure center from the bottom up. It has to start with dynorphins first, move into the endorphin system, and then regenerate the dopaminergic system. So what we do, y'all, is you put them into treatment. And with that treatment, you put them into groups. And these groups are made up of usually strangers. The only thing that they have in common is that other individuals in that group also have a substance use disorder. And what do we have them do? We have them talk about the impact of their substances on them. On them. They have to talk about them. They don't talk about other people. They don't talk about the weather. They talk about them. And then have other people get back and talk about that. And what happens, we see, and y'all have probably, some of you have seen this, I don't know all of you, as we do in traditional group therapy, people begin to get closer to each other because they begin to initiate a dynorphin or a bonding process. And I only have a 6-week program. It's pretty intense, but it's not long. So what happens is, and it's because they're safe, y'all. They develop that safety within that group because we think that dynorphin builds. Now, the dynorphin system has to regenerate enough in order to increase the endorphin system. And what the endorphin system does, y'all, as I told you already, not only does it help with pain, it helps eliminate some of that painful stuff, but also it helps begin to activate a reinforcement. You know, when you take a person in treatment in the first week or so, after we stabilize them, we're going to put them in a van with other people like them in their group, and we're going to take them out to recovery meetings. And oh my goodness, when you send somebody out for their first recovery meeting, it is like, oh, you killed me. I'm never going back. That's the worst place I've ever been. I don't not like the blah, 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 blah. Versus when they're getting ready to graduate in the 6 weeks and they've been to, 40 recovery meetings, guess what? They are now reinforced that that is a process that works. And so it's because of the dynorphin. As long as they stay involved with that system, they continue to improve and increase the dynorphins, we believe. And then they get to the endorphins to where they begin to reduce their pain. And also they increase the reinforcement of how recovery works. And by the time they get to the year, we've got almost 1/3 of those individuals that got a very good chance of staying in recovery for the rest of their lives. But it has to do with that safe housing component. It has to do with that dynorphin and that bonding. So if you got a person, I got them all the time that come in and they feel safe and then they go back to an active drinking situation at home, then we have to make a decision as a treatment team. Is this in their best interest? Do we need to do residential? And sometimes, and that I do residential from the standpoint of science more than I do from behaviors, because if they don't have safe housing or a safe place to go to, relapse is extremely high. Recognition of unconscious aspects of relapse. Again, relapse prevention, that's what that's for. Ritualistic daily, hourly stress management activities. I think we have gotten away from traditional stress management treatment modalities. I remember when I first came into treatment back in the mid-'80s, we always had relaxation, we had deep breathing, we had other alternatives. We got acupuncture now, all kinds of things to help people learn how to manage stress. That's not necessarily the case today. Supportive peers. Again, the dynorphin system has to be, these first 4 components really have to do with dynorphins. Medication, alpha and beta blockade. Now these are kind of theoretically what we look at from overstimulation, anti-craving components. And we have multiple ones, if we be, as I mentioned, Campril, naltrexone, the anxiety that may come out of that. And we can't use benzos, we use alpha and beta blockers as a result. And the minimization of social dominance, y'all, is where the ego and the person involved is not the center of the universe. They need to realize that they need to be a member of a family again. And so these are some of the things that we look at as it helps reduce the stress component, which triggers the craving component. And again, this is why you and your background and your training are very, very important in the management of these individuals. So when we look at the overview, the brief that they talk about, dopamine starts out with liking, occasional use. We talked about that. We look at the endorphins. It creates a reinforcement based on a pattern of use. And then as a result of overstimulation of the endorphin and dopamine, the dynorphins move in, try to replace those 2 diminishments. They're not, it's depleted. It creates the craving, which leads to what the technical word is, substance use disorder or an addiction. All has to do with the pairing pathways and the components of that. So what we have to do here is we have to increase the dynorphin for them to get better over time. How long does that take? 6 to 12 months. If we do that long enough, depending on lots of factors and things, then they increase the endorphins. And how long does that take? 6 to 12 months. So that's now at 24 months. And then if we do that long enough, the dopamine begins to regenerate on a day-to-day basis, and that takes 6 to 12 months. So by the time we can start looking at a completion of what this brain can heal, and it varies to individual, is about 3 months, 3 years. And so when we look at 36 months, the recovery rate goes from 35% to almost 85%. The longer they can do this, the more reinforcement they get, the longer, the better chance they have for long-term sobriety. If they stop the process for whatever reason, and a lot of people will tell you when they look at relapse, this dynorphin system, for some reason, unless they've replaced it with something else, they can go to religion, they can go to lots of things, but without human contact and human interaction and human stress relief as a result of healthy, intimate, trusting relationships, the brain will deplete itself again and cravings can return. And so that's the dilemma of it being a chronic disease. And then we look at the pathways, as I told you. Want a beer, makes me feel good, Miller Lite, VTA, as we look at those. And then here comes Dr. Koob, who is now the new director of the National Institute of Alcohol Abuse and Alcoholism. And again, what he says, the result is anhedonia, inability to find pleasure, normal pleasurable activities. The brain reverts to allostasis, the change of the hedonic set point under stress in an attempt to maintain stability. So you've got a normal brain and you get stressed. You may get anxious and you may get depressed, but if it's normal chemistry, it's going to try to put you in the middle so that you will be okay. And Joy's Guide, our program on average is a year for this very reason. Clients going IOP to OP and live in our subgroup. Yes, Joy, that is an extremely successful program if you have that available to you. But if they don't, if they move out of that environment and leave that individual contact, they revert back to what this brain is talking about. They revert back to an anhedonic brain where they lose pleasure in those simple things. And if they stay there long enough, it sets up, again, a craving mechanism that begins to change. Now, summarize normal reward brain pathways. Dopamine is released. Normally, we'll see happiness and joy. Eventually, the sources, the endorphins, dynorphins, are depleted, and you activate what we call the anti-reward brain. And again, what this means, y'all, is that the anti-reward brain in the substance use disordered individual does a couple of things. One, it triggers any kind of reward. Its job is not to have the person experience reward. So I don't like this meeting. I don't want to do this. I don't want to work this steps. I don't want to do blah, 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 blah. It triggers an excessive activity in the reward system trying to activate dopamine, but because it is not available, what does it do? It increases glutamate. And what happens is that compulsive behavior of the glutamate GABA release creates pain, depression, anxiety. And y'all, that is what I continue to say in the simplest terms, that's what they become addicted to, is pain, depression, anxiety. In other words, they'll self-sabotage to the nth degree unless they understand the disease and how it works in their brain to lead them to that place. And that's what all this is about, is trying to help them understand that they are wired for failure. They're not wired for success once that takes, the substance use disorder process takes over. So they're going to have to, as they say many times in a recovery group, they have to swim upstream. They have to do what's in best interest of them and not what's in best interest of their drug of choice. And that concept, y'all, may make perfect sense to us, but in the brain of an individual who suffers from a substance use disorder, it's a different language. It is a different language. So I try to use this information to help them understand why they act the way they do. Why did they self-sabotage and lose their job or lose their family or lose, and in the process of healthcare professionals, lose their careers? And this is what you have to do. So when we look at this pathway, and in a Knowles slide, and we show the different drugs of choice, alcohol being the least addicting, because it activates in higher levels of the brain versus cocaine and heroin. And see, what most people don't know is nicotine and heroin activated in the lowest parts of the brain, and that's why they become some of the most addicting and the most difficult to treat. See, the lower the process the brain occurs and biological components of changing of the pathways, the more difficult it is to treat them behaviorally. So what is the easiest one to treat? Alcohol. What's the most difficult one to treat? Opioids. They cannot get rid of that. They cannot, it is amazing to me. But when I tell people this, it has to be based on what we know about what the brain and how the brain changes. There are always exceptions to this, but I'm saying as you look at this, you begin to see. Now you keep adding other drugs of choice like cocaine, heroin, and nicotine, then you get to see why these individuals take much longer to treat because of multiple drugs of choice. So what Kevin and Koob said, the hypothesis of the dynorphin kappa opioid system, it's a key component to the neuroplasticity with stress-induced mood disorders and the dark side of addiction. Now, what is the dark side of addiction? It is not only the withdrawal, not only the physical withdrawal, but the emotional withdrawal of the drug of choice, and also the overwhelming negative affect that the individual presents is a result of the changes in the dynorphin kappa opioid reward system and the depletion of the dynorphin in the kappa opioid receptor system. And the endogenous cannabinoid peptides derived from polydynorphin encode creates a dysphoric, anxiogenic, and cognitive disruptive response to behavioral stress exposure. And that's a biological reason. Says if you put yourself into places where cues are being triggered biologically, you smell it, you taste it, you see it, you hear it, you touch it, it's going to create a cognitive disruptive response that's going to say, use this drug instead of going to a meeting. And it becomes an overwhelming process. And by the time I talk to individuals such as you that treat these individuals, we understand now why the burnout is so high in this profession when it comes to substance use disorder is because of the ongoing component of these individuals that reflects back to the professional. So they've got to take care of themselves too. When I say this, addiction is greater than a mother's love. The reason addicts cannot stop using once the dopaminergic system is depleted due to multiple neurobiological reasons, the reinforcing effects of the drug becomes more powerful than a mother's drug for her love for her children. In 2018, as it is in 2020, the potency of most street drugs, marijuana, heroin, have increased drastically. The increased potency creates the increased reinforcing effects of the dopamine, which that means is the increased reinforcing effects means they're going to increase the depletion of the dopamine faster, thus increasing the addiction liability of the drug. So when you've got a dab cannabinol that's 40%, it's going to deplete the brain much faster than a joint at 5%. And so you end up with these severely depleted brains that have cannabis use disorder, that have high anxiety and other types of things in them that require probably, as I'm going to discover, and we're going to discover this as more of this legalization goes on, longer treatment. But that's a part of it, is because of the dynorphin. In other words, drug of choice is more important than the family. Drug of choice is more important than the job, more important than the children, more important than anything else as a result of that. And so we see that. Then we affect the prefrontal cortex, which is your decision maker. And basically what the normal decision maker does is it contributes to your social behavior and also planning for enjoyment. You know, I'm looking forward to lunch, been looking forward to lunch before we started. Because we'll take a break. You understand what I'm saying? We'll take a break. And when we take a break, we'll have some time to, you know, sit down and drink water or talk to the family or pet the dog. I mean, we'll see Elvis. I got He's my little grand dog, and he's all excited about coming in here. Now, he may be in here with us the second half of this lecture today, and he likes to get up here in my lap, and he's just a great dog. He's a great dog, 15 years old. But the thing about it is, I want to see him because he's a great dog, and enjoy that, because that's what my normal brain does. Addicted brains, though, what they do is their primary function is to look for the drug of choice at the expense of other aspects of normal life. And that's one of the biggest things. That's the prefrontal cortex. So the plan is changed. And then we look at the nucleus accumbens, and that's a type of euphoria. It's kind of like, sweet thing, you make me feel so good. It's the main part of the reward pathway of the brain. It processes rewarding aspects of experiences: food, water, sex, exercise, vacations, pay raises, awards at work. I won an Emmy about 2 years ago for a documentary I put together, a real Emmy, and it's really a highlight. And anytime I really, say, well, maybe my teaching's not good or I messed up on something, then guess what? I kind of go back and look at the Emmy. I mean, I've got it right here in the office, and maybe I'll put it on the video and show it to y'all. But the thing about it is, it's pretty cool, because not many college professors get that opportunity. There's only, I think at the University of Georgia total, there's only been 3 Emmys won by the entire history of UGA faculty. And it's wonderful. It's a wonderful thing. But the thing about it is, we have those normal rewarding aspects because of things that we've accomplished. You all have them. It can be your children, it could be family, it could be professional, whatever. That's normal. But the addicted brain, the dopamine production for some of the drugs causes that depletion. And so guess what? You're not thinking about those normal rewarding behaviors, you're thinking about the drug of choice. And so it not only affects the prefrontal cortex, it also affects the nucleus accumbens. So here's self-assessment question 10. The opioid that has the highest potency, addiction liability, on the opioid receptor is morphine, codeine, hydrocodone, fentanyl, oxycodone. Y'all know where we're heading with this, don't you? It is fentanyl. It is D. Excellent. Y'all make 100 on my exam, because my exam is very easy. Y'all know that I do not like testing any type of post-op. I don't. I'm not fond of written tests, even though they're required. So you're not going to have no horrendous, oh my God, what's it going to do? It'll be simple, y'all. Y'all will be able to, trust me. As long as y'all can apply this information to your practices starting Monday, I'm happy with you. You understand? So y'all don't stress on this. I'm not trying to get you, and there's a lot of complicated things could be it, but I'm not going to do it. Y'all have a simple, you'd be real good. But the thing about it is, fentanyl, fentanyl is about 200 times more potent than morphine. Sufentanil is 400 times more potent than morphine. And alpha sufentanil, which is derivatives of fentanyl, is almost 500 times more potent than fentanyl. Now, what we use those for is anesthesia. Now, fentanyl now, of course, it's still used as anesthesia and some pain management, but we use it in a step down through patches, and we don't have oral preparations for it. We have a nasal spray. But the thing about it is, we're very limited. These are things we don't want to use except for last resorts. So the potency is, but we got fentanyl on the street, and a lot of the overdoses and deaths that are being created today is a combination of fentanyl, another opioid, or fentanyl and benzodiazepines and fentanyl. So I'm making sure that people understand that fentanyl is a very potent. It's measured in micrograms, and we'll go through that when I get to that probably tomorrow. But anyway, this is good. All right. So when we look at what happens overall in the substance use disordered industry, and when we look in the brain, then we look at to see what we got. We change the receptors, the mu, the kappa, and delta, and we'll talk a little bit about those, and the euphoria that is. We change the overall opioid peptide system in endorphins and dynorphin. We change the cellular membrane activity by downregulation of GTP to GDP, and what that does is create a release of beta-arrestins And what beta-arrestins are the pain blocking chemicals at the receptor site on the cell membrane. But when you activate too much of them, it creates tolerance. We change the pathways of dopamine by decreasing production, storage, and transport. And then the brain-derived neurotropic factor changes that it may create psychiatric mood dysregulation, such as anhedonia, major depression, OCD, manic psychosis. I mean, all kinds of different things can happen as a result of those folks taking these medications, as y'all well know. So we will see how this works. All right, let me see. So opioid receptors are now thought to be called the euphoria receptor. Scientists have indicated that opioid receptor may have similar shapes to a bundle of dynamite sticks. In other words, imagine a bundle of dynamite sticks. In this bundle, it is believed to contain 7 helix. In other words, each stick is a helix, which each helix having pain reduction capabilities of various degrees. Now, hear me when I say bundle of sticks, 7 sticks, each stick has a pain reduction capability. So there's 7 sticks in this bundle, okay? Now, for instance, and let me see if I got this, hang on. Yeah, there we go. There we go, okay, good. All right, let me go back. So we look at the receptor, we got a mu receptor, we got a delta receptor, we got a kappa receptor, okay? Y'all got that? And everybody seems to know about the mu receptor. It's something that we tend to, I don't know why this will move, there we go. Let me move it, there we go. Okay. So y'all can see the slide. Activated by morphine or morphine derivatives. Most everything in the opioid world is metabolized to morphine, by the way. Primary action, all opioids distributed through the central nervous system and also GI gut. It is linked with substance use disorder. The delta is the endogenous peptide. It's for nerve conduction. It is simply slows pain signals between the peripheral nervous system and the central nervous system. It acts through the brain hypothalamus. So dopamine affects mu. Endorphins affects delta. Dynorphins affect kappa. Kappa's analgesic, has endocrine changes, dysphoria. It's located in the brain, amygdala, spinal cord. It's stress reduction. And they all create pain relief, but you understand these other activities that they have. And so that's one of the things that I will tell you is that we have all of this connected together. And so we have the mu, delta, kappa, dopamine, endorphins, dynorphins, okay? So when we look at the receptor, there's 5 classes. We've got all those. When we look at the structural characteristics, there's different types of helixes, okay? They're usually typically G protein coupled. There's 7 different regions, 3 intercellular, 3 extracellular, and 1 it's got a carboxyl tail, 1 extracellular has got a amino terminal tail. And what that means is the more regions within this receptor that you affect, the more addiction, the higher the addiction liability. So when I look at opioids, aspirin, for instance, a non-steroidal, will affect 1 helix. Aleve, naproxen, will affect 1.5 helix. Ibuprofen will affect 1.5 helix. You understand? So the over-the-counter aspirin and Aleve and Motrin, ibuprofen are good for moderate, mild pain. We got codeine by itself, 1 helix. It affects the same as aspirin. But in the prescription world, if we combine aspirin with codeine, it will cover the same equivalent as hydrocodone. And hydrocodone, as you see, affects 3 components, 3 helix. So aspirin plus codeine equals 3. So we got Tylenol number 3, Tylenol number 4, Tylenol number 2. A lot of dentists and others will give that for moderate pain short term. But people can't tolerate codeine. They're allergic to it, so they come out with derivatives, codone, hydrocodone, oxycodone. And those derivatives affect approximately, hydrocodone affects 3 helix, depending on dose. Oxycodone, depending on dose, can affect 3 to 3.5 helix. But the bad baby boy, the one that is the big boy that does it the most and does it the best, is morphine. It affects 4 helix. Yay! So we use morphine under pretty strict restrictions, usually in the hospital or in clinics or something where there's moderate to severe pain short term. But it has to be monitored, because when you affect that 4th helix, y'all, you also start to affect respiration. So we have to be careful. You start anything that goes over 4, 5, 6, and the oxycodones can go to 4.5 and to 5, depending on the dose. Hydrocodone high doses can go to 4 to 5, depending on the dose. You hear what I'm saying? Fentanyl, which we just talked about, covers all 7 times 3. So fentanyl is extremely potent and also extremely dangerous as a result of the helix and the combination. So if you was to take a fentanyl, even at a regular dose, and a benzodiazepine, your respiration, for instance, normal respiration is about 18. You take a fentanyl patch, it will reduce your respiration. Most people might not be aware of this. It can reduce your respirations, if you don't have tolerance, down to 14. You take a benzo down that, you can reduce that respiration down to 12. You understand what I'm saying? So you've got respirations that are reduced by 1/3. You've got some problems, and can have some very serious problems. But this is what it's all about. So we have the transmitters, dopamine, endorphins, dynorphins. We have the opioid receptors, mu, kappa, delta. And then we have the helix within inside of the receptors, depending on which one, 1 through 7, multiples, depending on the drug and the opioid, can affect multiple ones. So you begin to see the complications and why pain management, as we know it, takes specific training over time. Being trained in pain management for many years, it is something that I have to pay close attention to every year, that we have to update, because all of these medications, we've got 3 new opioids coming out in the next month. We've got new applications of these opioids, and not only with the medications, but also procedures and other things. So you see why it's so difficult to create appropriate pain management. Acute pain, pretty straightforward. Chronic pain, much different and much more complicated. And again, that article in National Geographic was very helpful in understanding the complications of the 7 levels that are required to manage that pain and all the differences there. Now, also that we have here is neuroadaptation. The more a drug is used, the more the brain gets accustomed to it, as we've mentioned before. It can cause long-term changes in the nervous system. This begins to change the mesolimbic dopaminergic system circuits, which is one of the 3 circuits that we have with dopamine. Ultimately, it leads to an increased tolerance in the drug. So the longer you take a psychoactive drug that is affecting the dopaminergic system, the more likely you're going to increase tolerance. That means the same, it's going to take more and more of the drug to get the same effect until it's saturated. And they are certain drugs that also have what we call reverse tolerance, which means it takes less and less of the drug to create the same effect. And this is due to either damage to an organ system or absorption, complete absorption into the adipose system in the central nervous system. Marijuana will do that. Cannabinoids will do that. The liver will be destroyed by benzos, opioids, and also alcohol. And so you can have a damaged organ or concentration of the drug inside the adipose tissue that cannot be absorbed anymore, and you'll have reverse tolerance. So we can have either one of those. So, and then we have positive and negative reinforcers, and we're going to talk about that in a little bit. I'm going to try to get that. So this is kind of review. We've got sensitization and adaptation. So you begin out with lacking. It activates the first circuit, and dopaminergic circuits inside of the brain, and they're kind of in the prefrontal cortex and the midbrain regions, may trickle down into the instinctual brain. But as you increase your dose and increase your pattern of use, it begins to integrate into the endorphin system, and that system integrates from prefrontal cortex, midbrain region into the instinctual tracts, into the management system of pain. And then as you increase that, it goes into the third system, which is the dynorphin system. And as a result of the alteration and changing of that amount and possible depletion of that, it creates a craving or a circuit 3 that causes a reverse. And that's kind of how we do it. And that occurs over months or years, depending on the first stage of use of the brain and the use of the particular drug. Fentanyl can create an addiction within a week. It's that potent. Alcohol, very unlikely to create addiction over several months or years, depending on who and how much they use it. Now, again, normal use, and I'll put this down, normal use comes about with this, and this is just a reinforcing slide. I want a beer. It makes me feel good. Miller Lite, that is normal. And then as a result of this, we move from a dependent state, craving as new diet. So when we look at this A slide, and we look at the A slide, and it's important that we look at it from that standpoint, we have an increased dopamine, whoopee, 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 high amounts, and it will last for a period of hours. And then if you say it was drinking, as a result of that, and you may increase your dose more than normal, you will go through an increased CRF. And what that CRF is about, y'all, is an increased withdrawal or hangover. And after a series of hours of that, that hangover will go back to normal. And so you have a Saturday night, y'all may be drinking a lot of beer tonight, and you may have a hangover tomorrow. Excuse me. I'm trying to get it back. Come on, let's go back. Back. No. I want to go back. So here we go. And so what happens to go back to normal, and then you can drink again here next week or so. A dependent brain, though, has already got a depletion of dopamine. So when they drink, even though they may drink even a higher dose than here, all that dopamine does, instead of going whoopee up here in a normal brain, it goes whoopee, whoopee, whoopee. So what the individual does is he increases the dose, and as he increases the dose, what he don't know, the brain actually decreases the dopamine because of there's not enough dopamine. There's a surge of glutamate. There's a spillover, and so that dopamine is diminished. It also creates an increased CRF. So what most people don't know about dependent individuals is that the more they use, the longer the withdrawal will be. And so instead of having a withdrawal that lasts for a few hours, they have a withdrawal that lasts for days. And even with that, let's say they get through the withdrawal, brain will come back up to another, what we call, Kubes talks about allostatic set point. He sits it right here, and yes, guess what? There's a distance between the allostatic set point and the homeostatic set point, and so guess what? The difference is the craving. So the brain is always trying to go back to homeostasis, but it's at allostasis, and so that craving is trying to help the brain reset itself, and there's no way to do that normally unless they go back and try to use the drug of choice. And so that's where you see the cravings come in. So cravings have basically been added to the DSM-5, and you will see that in some of your cases. And so as a result of that, craving is a memory of a rewarding aspect, drug superimposed on a negative emotional state. It compels drug seeking in a dependent individual. There are three different types. Withdrawal induced, which means people will crave their drug of choice or drugs of choice immediately after stopping. which is within the first few hours, days, or weeks of stopping use. There's drug-induced, which I am for the first time going to be able to talk about tomorrow in treatment aspects of understanding they are medications, both prescription and over-the-counter, that can lead to relapse. And unintentionally, people take over-the-counter medications for various reasons that create cravings. And then cue-induced, which means these people now are exposed to people, places, and things that activate that D-FOS-B memory system that's in the nucleus accumbens, and it creates that craving from the standpoint, I want you to use the same amount you used last time to get the same experience. And that's cue-induced. And so as a result of that, we have the 3 types of cravings. And this is biologically what happens. You have the glutamate, the dopamine, and the nucleus accumbens, normal brain, whoopee, ouch, whoopee. The brain tries to put it in the middle, so you see the amounts according to the arrows are about the same. When you start to use more regularly and in acute cocaine, you will see an increase of dopamine because of the increased dopamine and the reinforcement effects of that. And so what happens is you have glutamate, and that glutamate comes out, and again, it begins to see what happens. And so when we have that, all right, you got a voice issue? Dula, you have a voice issue? Can y'all hear me? Static.
I can hear you.
Okay, thank you. All right. Heather, can you, all right. We're about done. I'll see if I'll go to a headset. That may be part of it, but I don't know that. Right now I'm not working from a headset. Okay. All right, fine. It may be reception. I don't know that. All right, so back to acute. So you have the dopamine and endorphin system. You see the increase in the area here. Glutamate is still basically the same. And so you're going to get a high. You're going to get euphoric because the glutamate has not had time to activate to catch up with the increased dopamine. So as we see with continual use, chronic use, again, you see the increase, the maximum amount of dopamine being used. And then you also see the increased glutamate, which can be from the increased amount of the brain increasing it, and also because of what we call the spillover. And then what happens is the nucleus accumbens is overstimulated, and instead of looking at a reward brain like we do up here, we see a craving, relapse, paranoia. And then as a result of stopping, y'all, and again, I'll move this around, of stopping, going to treatment or whatever it may be, when you stop that amount of dopamine from here to here, you still have that increased glutamate, and guess what happens? You have the increased craving and relapse as a result of that. And so we have that circumstance. So we have the different types of craving. One is type 1, that's cue-induced. And I want to try to get this done with this before we go to lunch. We have the second type, which is stress-induced, or as a result of a negative emotional state. So we have cue-induced, stress-induced. Most people's cravings, based on the research that has been done, has to do with combination of both of those. And so we have to manage that. Again, the definition, positive reinforcement is due to increased response and release of dopamine in the beginning, which is a good thing. It creates impulsivity. Negative reinforcement is, again, the process which removal of adverse stimulus, negative emotional state, usually as a result of having not enough dopamine present and too much glutamate present. And so what happens is you have a negative component to one's life. So what happens in the beginning, how a person develops substance use disorder? We're going to wrap this up so we can get done. Starts out with occasional use of alcohol, marijuana, prescription drugs. Average age of first use in this country is 14. At that age, the brain is not mature, doesn't really complete biologically maturity to between the ages of 24 to 28, depending on gender. Women mature faster than men. The immaturity creates a risk factor for this substance use disorder. Now, then we look at, yeah, that's it. That's what I want. Then we look at genetics, and if we're going to look at genetics, we got biology and genes. We talked about the biology pretty extensively. We'll look about the genes and the environment that we've mentioned already. And Dr. Crete, who is the founder of the genome, she started in 1964, says that in a circle, if you had the risk factors listed, genetics play anywhere from 25 to 50% in developing a substance use disorder. Environment, in fact, has a 25% influence, and it increases with premature use prenatally and exposure postnatally in the first 3 years. So if you have that, that percentage can increase. And also if the individual has a comorbid mental disorder going along with the addiction. Drug-induced effects have a 25% increase influence. And this has to do with the changes in the messenger RNA. And this all relates to, y'all, drug-induced effects all relates to the changes in potency that alters messenger RNA. Our DNA is hardwired, messenger RNA is soft-wired, so the messenger RNA is the thing that's impacted the most with active use in most individuals. Now, so initially a person takes a drug hoping to change mind, mood, perception, hoping to change their brains, right? Okay. We know that despite the differences, most abuse substances enhance dopamine and serotonin pathways. We talked about dopaminergic system. We'll talk about serotonin after lunch. Then you add the changes to the chemicals responsible for feeling good, dopamine and its family members that come with regular use of alcohol and other drugs. Here are the essential 11: epinephrine, norepinephrine, serotonin, GABA, endorphins, acetylcholine, anandamide, glutamate, dopamine, PIP, which is the attractiveness chemicals that are involved in humans, attractiveness of other humans, falling in love, dynorphins, bonding and loving oneself and others, possibly has a spiritual component to it where we bond to religion or spiritual aspects of our lives. So the neurobiology of reward is understood for decades, whereas neurobiology of addiction is still being explored. Most scientists have learned that reward pathways include projections from the VTA, which is the memory of our greatest pleasures, through the middle forebrain bundle, our pleasure pathway, and terminating in the nucleus accumbens, which gives us the type of pleasure experience, all which have dopamine neurons, which are prominent. So these, again, the science indicates where all of this is located. Current neuroscience recognizes that the neurocircuitry of reward also has a rich bidirectional circuitry connected to the nucleus accumbens and the basal forebrain. This means that the brain has several different pleasure pathways. Thus, the brain may experience different types of pleasure from various drugs of abuse, and I should add, behaviors. It is the reward circuitry where the reward is registered and where the most fundamental rewards, such as food, hydration, sex, nurturing, exert a strong and life-sustaining influence, okay? Bidirectional. Y'all see that? So in one direction, like, want, love. Like, want, love. Like, want, love. Normal. In the world of addiction, when you change the like, it turns into dislike. And when you change endorphins into pain relief, it changes it into pain. Dislike, pain. When you have the depletion of the dynorphin, when you have dynorphins, you have bonding and stress reduction. When you deplete them, guess what? You have a lack of bonding, especially in intimate relationships, families, and no stress reduction. So you end up with a brain that cannot manage stress, is not bonded to any human or human components, lack of bonding, I should say, lack of pain relief, and a tremendous dislike because they're in an anti-reward brain Now you have a perception of what it is to be substance use disorder. And that, I think, is where I'm going to end that and wrap it up after lunch. Okay? Now, before we leave, this is what I'd like for you to do. We're going to be gone an hour. I'm going to be gone an hour. If y'all would please, do me and Ever really were tour? No, not really. Except me. I'm the only difference to that in the research I've found, yes. I want you to have your questions sent to me, text them to me, and what I'll do is answer your questions as best I can before we move on. Okay? Any questions about that? All right, y'all. Let's have a nice lunch and we come back. Now, if y'all want to have less time and leave early, y'all also need to let me know that too. Do y'all want to have a 45-minute lunch and come back and we leave a little early, or what? But everybody has to agree to it. I can't do it otherwise. Leave early.
Doctor, sorry that I am interrupting. Is a regulation by the school to have 1 hour lunch break?
Okay, well, 1 hour it is then. We won't
My
be able to do
apologies.
that. Gotcha. All right.
Oops.
That answers that question. The administration's done okay. Okay, I'll see y'all in an hour then. Thank y'all.